and Cognard et al. This is the most accepted one. So we have to classify or grade whether we are having benign venous drainage pattern. The venous drainage pattern is the most important, or aggressive venous drainage pattern. So if we focus on this, this is dural sinus, this is cortical vein, and this is the arterial supply. So the grade 1, when it drains, the artery drains into the dural sinus only, and it is going as per the normal drainage. It is not refluxing. But in grade 2A, that is draining into dural sinus, and there is some sinus reflux is also present. So blood is going this way also and this way also. Third, when it is going into the sinus as well as the cortical vein, this is again increasing our chances of hemorrhage and all those things. And this is the most complex one, when it is draining antegrade, retrograde into the cortical veins. So these are the most complex cases, and these most of the time present to us with hemorrhage, headache, seizure because of venous hypertension. Another, when the artery is directly contacting some cortical vein, and there is venous reflux toward to the venous sinuses. And the most important one, when we are having direct venous drainage and there is venous ectasia. And these are the cases who are the most complex one, and most of the time these cases presented with hemorrhage. So after understanding this, we can go toward the management. There are 3 things we can do. Surgery. Surgery is most of the time complex. It requires craniotomy, handling and stretching of the brain, hemorrhages, or there are high chances of vessel occlusion, because you have to hold those arteries very much proximally and ligate them, and these arteries can be injured. The gamma knife surgery, in selected cases where either surgery or endovascular treatment is cannot be done, but it is not having much role, because wherever there is high flow situation, whether it is high flow AVM or high flow fistulas, the GKRS most of the time fail, because it creates inflammation there in the vascular bed and cause thrombosis. But because of high flow and continuous supply of oxygen and everything, producing inflammation into that bed is very much difficult. And endovascular intervention, it plays the central role, and it can be done through transarterial, which is the favored route, and transvenous when there are so many feeders, hundreds and thousands of feeders, and we are having approachable single, double, or triple. So in those cases, transvenous approach. But this transvenous approach is most of the time is not available, because all these patients, they are associated, having associated thrombosis or venous stenosis. So now we will discuss all these points in these cases. So this was a 29-year-old male who presented, who was operated for meningioma in 2020 somewhere periphery, and records were not available. So this patient presented to us after 3 years of that surgery, and it was having headache since then, and now increased from last 3 months. He was having diminution of vision, diplopia, and dizziness. And if we see the diagnostic DSA, this is right CCA injection, and we can see the complex fistula out here. The fistula is there, which is supplied by the middle meningeal and occipital artery, and multiple feeders from, if we see the internal carotid artery, the meningeal branches going to the bed of fistula, and this ophthalmic artery or some branches, they are also going and joining superficial sagittal sinus. So if we see here these draining veins are seen. So this is right ECA or internal maxillary injection, and here we can see we are having feeders from the distal most branches, from the internal maxillary, from middle meningeal, direct fistula, and superficial temporal going, and tortuous vessels which are going directly through this point. So we are having fistula at this point, we are having fistula at this point. So very much complex case. On the left side also we can see again there are multiple arterial feeders, numerous arterial feeders for superficial temporal going all the way to the mid part of superficial sagittal sinus. There is a direct fistula at this place. This is a draining vein. This is going, and on the way this draining vein getting more supply from these arteries. So there are multiple place fistula, like fistula here, and fistula here. So this is one of the very much complex case, and how to deal with the patient is having severe headaches because of this, and diminution of vision also. So this is the late phase of the left external carotid. This is left internal carotid injection. We can see like ophthalmic artery through the superficial trochlear branch going all the way posteriorly with this meningeal, and it is also supplying here. So as I told, this is one of the most complex disease in the vascular, cerebral vascular cases. So we started this case for endovascular embolization in a staging manner, and this is the right vertebral again. So all the arteries are supplying bilateral ECA, bilateral ICA, and above all the vertebral artery also supplying this sigmoid sinus fistula here. So hundreds of feeders. So, but you need not to chase all of those, because the disease is at the venous wall and venous sinus. So if we from any of the feeder, if we go to the bed, and if we can occlude that, and if we are able to reflux our onyx into those another arteries, the treatment is possible in these cases. So this is the therapeutic DSA. In this, we chose, this is the microcatheter runs. We always take microcatheter runs of major arteries so that we can take the decision in first sitting, a very good run in the fistula situation or the small arteries. So for that, what we use the Onyx 1 ml syringe and take 100% contrast in that. So that can create the enough dose and enough opacity into that feeder. So this is the occipital artery we can see, and we entered the middle meningeal, and further Onyx 18 was injected into this, and in first sitting with available Onyx, we could achieve around 20 to 30% embolization of this. And this patient is planned for future sittings. So next case, tentorial or sigmoid, 53-year-old male patient presented with chronic headache. First sitting was done in COVID times, and the patient was having improvement in systems and then symptoms, and lost to follow-up. Reported again with the chronic headaches, and which were increased in the severity. So reported again for the treatment, and we can see this is CCA run, and we are having supply from the occipital, we are having middle meningeal. So multiple supply, we are having supply from the internal maxillary as internal carotid also. So this is the ECA run. In this, we are going to take the micro run of this artery, this artery, this artery, and this artery. All these arteries to actually go into these details. Which of these are supplying the most? Mostly it is middle meningeal artery, and if we are able to get into the middle meningeal artery, and if we are able to get into the bed of the disease, the treatment is possible. So this is the onyx cast of first sitting. In first sitting, we went through the middle meningeal. This was the feeder, but somehow the onyx did not percolate well. The scepter was kept here, and inflating scepter, the onyx was injected, and some of the occipital feeders were also taken into for embolization in that sitting. But now the patient is having significant feeders from this part of middle meningeal, which is going here also, superiorly also, but this middle meningeal is, this is the occipital run, this is the run distal to the middle meningeal. We can see the distal artery, the distal internal maxillary artery is also coming retrograde and medially and supplying this fistula bed. So what I was planning to have scepter at this place, keeping the tip here and inflating the scepter and injecting the onyx by pressure into this. But there was a risk of going onyx to this. So we changed our plan and took 3 centimeter Apollo and went somewhere deep inside here. So this was the microcatheterization onto the fistula bed. This is the maximum distal position we could reach there, and then sequential onyx injection. We can see onyx is percolating well. Then you have to wait and inject. And for treating these fistulas, you must have very much patience in treating these, and you have to wait and watch where your onyx is going further, whether it is refluxing toward the arterial side also, and whether it is safe. So we have to plan our things very much meticulously and keep on seeing on the biplane where our onyx is going. So this is on the further injections. We can see onyx is going to the new places further, and after injection about 20 to 25 minutes, 3 to 4 vials of onyx, we could achieve the complete embolization of this, which we can see on these check runs, common carotid check runs. There is no blush out here, nothing is seen here. And this is the post-op CT. We can see the onyx cast here, which is there into the sigmoid and jugular region. So this patient is keeping fine. This another case which presented with the frontal ethmoidal, 42-year-old male, off and on headache, occasional visual deficiencies, now present with sudden increase in headache and NCCT. It was showing a small ICH in the left frontal and basifrontal area. So the diagnostic DSA, right CCA runs, shows the ophthalmic artery supplying this fistula here near the anterior part of cribriform plate and superior ethmoids. So it is getting supply from the ophthalmic artery and part of internal maxillary artery. So This is the ECA run. We can see the internal maxillary artery, and very tiny arteries are going to the fistula bed and supplying this fistula. So this is the ICA run. We can see the internal maxillary, ophthalmic artery supplying this bed, and this venous channel going and draining into the superficial sinus, and these are the communications. So initially we thought we can go transvenous and enter here, but there is, at this place, this vein is not directly meeting the superficial sinus. Rather, there were some small venules or some venous stenosis, and that was the reason of bleed in this particular patient. So transvenous side was not very much possible in this patient, which would have been better for this patient. So ophthalmic artery supply on zoom, the left CCA run showing the ophthalmic supply and maxillary also. So these are maxillary runs and showing multiple tiny arterial feeder going to the fistula bed, and but we cannot reach here. So what to do? We planned, and I was trying to avoid the entry into the ophthalmic artery on either side, because there is high risk of regurgitation of the onyx or any embolic material toward the central retinal artery. So this is very much important. So in first sitting, we went through the left internal maxillary artery and hoping that my onyx cast is going to the bed as well as on the venous side. So this is the cannulation of distal internal maxillary artery. This loop is made to avoid the stucking of this micro wire into the multiple side branch, and so that we can reach as distal as possible. So we have reached here. So at this place, the septum is inflated, and the microcatheter tip is somewhere here, very much close to the fistula. So this is progressive onyx injection, and we can see the onyx is beautifully going. It is not regurgitating back into our artery, going directly toward the fistula, and we could achieve this much penetration, and after that the onyx start going some here and there into athmatal branches or so. So at this point there was reflux around the balloon also. So we took out and stopped at this place, and on checking we can see the fistula is still filling from the ophthalmic, left ophthalmic, from right ophthalmic, and internal maxillary. So the patient had some reduction in the headache, and the patient was planned for the second sitting. On second sitting, we gone through the right ophthalmic because there was no other options left now, and right internal maxillary. So this time we can see the internal maxillary artery is supplying the fistula bed. This is the ophthalmic artery supplying the fistula bed. But this is tortuous and very much important for the juniors. We must see the course of ophthalmic artery. This is going like this and this and this and this. So this genu is very much important, and this is the place where these arteries for central retinal or ciliary artery, they supply the retina. And whenever we are embolizing, we have to go far off somewhere here. We should never stop here or here, and we should not allow any reflux, because just for treating patient, just for minor hemorrhage or headaches, we should not cause the permanent vision loss, because the patient cannot be treated. Once your embolic material is into the central retinal artery, you cannot do anything. You cannot save the eye, and patient will have complete blindness on that particular eye then and there. So this is very much important to understand. So this is the choroidal blush we can see here. So again, this is the ophthalmic artery run, and this is again for our junior this thing. So this is the ophthalmic artery, and this is the genu, and we can see, beautifully see, and this is the blush. So one has to understand these things very much carefully, that in the aggression of treating, we are not giving this patient a blindness. So the catheter was taken far, very much near, and my retinal arteries are somewhere here. So I am far off from this place, somewhere here. So at this place I can inject comfortably, and this is the injection of onyx. And in this we took Apollo 1.5, not the 3, because if we are taking 3, that detachment zone is going to come proximal in the stator segment of ophthalmic artery, and that can cause thrombus formation till the main ophthalmic artery, and that can again cause the blindness. So choice of your microcatheter is also important. So this is, so I'll rush, then internal maxillary artery, some of the ambulation, and this is in last. Again, in the last, we went again through the left ophthalmic, and the access was a bit difficult, but we could get it, and again we could reach very much near to the fistula, and this time we could achieve the reflux into the proximal vein, which is very much important. Once this vein is getting occluded, and this is going to create thrombosis in rest of the part, so you may not need to cannulate the other feeders. So this time the venous regurgitation, and this is the final onyx cast, and we can see like the ophthalmic artery is patent, and the choroidal blush is there, and the patient was not having any problem with the vision. So this patient, even after this, the patient was having some supply from the ophthalmic artery on right side. So we choose to wait, and after 6 months we can see that there is complete stable occlusion of this fistula. So this is the way we can treat these patients. So to conclude, these are complex vascular entity, detailed anatomical knowledge and angio architecture is must before going into the treatment of these patients. Skill and experience is required. Microcatheter runs are very much important to see the exact component of each artery. The choice of treating route and hardware, again, it is utmost important when you are going to use pressure cooker, when you are going to use detachable tip. The detachable tip microcatheter we can use when we are reaching very much close to the nidus. But if we are not very much close to the nidus, then we can use pressure cooker or balloons. Avoid any new neurological deficit, because these patients on the symptomatology, they are not that much serious, but the patient are having chronic headache or this thing. So we should, the aim should be avoid any vision loss or any cranial nerve palsies. The endovascular management is safe and plays central role. So this is my lab and my team. I thank them all and all patients, and thank you all.
Thank you, Ajay. It was a very exciting talk. You covered a lot of complexities that are involved with this complex topic of dural AVF, and your case examples were exemplary. So thank you. We can take questions at the end. Okay, so can we move on to the next speaker? Next speaker is Dr. Swati Halbe. She is a chief interventional neuroradiologist at Apollo Hospital, Chennai. And she's going to talk on keratoco-cavernous fistula. How do I manage it?
No. No, nothing is coming there. He's saying something.
Okay.
Oh, ऐसे रखेंगे क्या? Okay, that's fine. Good morning. Thank you, Dr. Shiva, for inviting for this conference and for a great hospitality. And it's a beautiful city. I come from Chennai and I was thinking, oh, this is a coastal city, so it will be same hot and humid like Chennai, Bombay, Goa, but it's such a pleasant weather also. Wish we can stay here for a longer time. Dr. Ajay Kumar has made life easier for me because what I'm going to talk is almost going to be little extension or application of the talk what he has given. Usually we don't speak much about carotico-cavernous fistulas in most of our conferences, but luckily I do get a lot of cases because of my association with Shankar Netralaya. And from all over India, somehow ophthalmologists other places never suspect that patient is having CCF if patient is having chemosis and proptosis. And they get treated for this thyroid thing and steroids and all that. And finally they land up there. And there is something called blood in Schlem's canal. And this always the ophthalmologist in Shankar Netralaya find that and they suspect CCF correctly and patients come. So this is something basic for students if they are there. I was not sure about the target audience. So they are either spontaneous or acquired. Spontaneous are more common, acquired are most of the times post-traumatic. Other classification is they can be very high flow fistulas or sometimes they are very low flow also, and direct or indirect fistulas. So we will come to that slowly. So of that type A fistulas are the real fistula. That means there is no vascular malformation in between. The right internal or left internal carotid artery gets ruptured and completely opens up into the cavernous sinus with no intervening vascular malformation in between. So this is a real fistula. But for type B, C, and D, that fistula word is a misnomer because they are actually dural arteriovenous malformations of the cavernous sinus region. And the classification comes because of their arterial supply. So if those fistulas are supplied only by the internal carotid artery branches, that is dural branches of ICA, they are called type B, and which is a rare type. They are not very commonly seen. If only ECA branches are supplying the fistula, they are called type C. They are comparatively okay, they are seen sometimes. But the most common type is type D, where both ECA and ICA branches supply the fistula, and they are the most common to be seen. In fact, they are more common in my practice to be seen compared to even type A fistulas. Now, these are just examples. Here you can see history of road traffic accident, and where the artery is attached to the dura, at that level, that shear stress just opens up the artery, and luckily it opens up in the cavernous sinus and does not bleed inside the brain, killing the patient. So here you can see the artery has opened up. Now, most important thing in CCF is that we have to see the venous drainage because the patient's clinical symptoms and our treatment strategies depend on the venous drainage. So venous drainage can be like in this patient, they're just moving like this. Anterior, that is commonly in the superior ophthalmic vein, and that gives us the symptoms of this chemosis, proptosis, and palsies. Posterior venous drainage into the petrosal sinus, inferior petrosal sinus. Oh, this is very unstable. You have pointer is there, please? So that causes usually tinnitus, and inferior petrosal sinus, if it is draining, it causes tinnitus. If you have such a massive anterior venous drainage, you will have only ophthalmic symptoms, tinnitus won't be there. Now, type B fistula, here only you can see bilateral internal carotid artery dural branches are supplying. There was no supply come from ECA. This is type C, where only ECA is supplying and not ICA at all. Now, if you come to etiology, thank you. If you come to etiology, the commonest etiology of CCF, which is direct CCF, is trauma. But don't forget that rupture of intracavernous ICI aneurysm into cavernous sinus also presents in the same manner. And more importantly, collagen vascular syndromes, fibromuscular dysplasias can also cause this. The note of caution for these patients is that most of these collagen vascular disease type of patients may present with bilateral CCFs. Bilateral spontaneous type A CCFs, you should have your ears, hands, everything on, up, because these are the patients whose vessel walls are extremely fragile, and even diagnostic angiograms can lead you into major problems. During my training in Sri Chitra, that time I remember when spontaneous bilateral CCF, the lady must have had collagen vascular syndrome, and in the diagnostic angiogram itself, after some time catheter and guide wire were not seen. Catheter and guide wire had perforated the aorta, and they were lying outside the aorta because that fragile the walls are. So bilateral spontaneous CCF, think of collagen vascular disease and be very, very careful when you perform the procedures. Indirect CCFs, usually they just start by themselves, but these are supposed to be factors which can trigger pregnancy, sinusitis, trauma. Day before yesterday, I had a patient who had pregnancy-related, maybe, because she said after 40 days of delivering the child, she developed this chemosis, proptosis, and all those things with no other history. Surgical procedures and cavernous sinus thrombosis. So secondary to that, this indirect CCFs can develop. In type A CCF, another thing which I forgot to mention was iatrogenic trauma. Transphenoidal pituitary surgeries or other face surgeries that ENT surgeons do, that FESS. So endoscopic sinus surgeries can also lead to trauma of the cavernous segment of the ICA and lead to CCFs. Now, as I told you, the clinical features thoroughly depend on patient's venous drainage, not on the etiology of your fistula. You may be having massive chemosis and proptosis, and you think it is a type A fistula, but no, it may be just a type D fistula alone. Anterior venous drainage, all symptoms in the eye. Posterior venous drainage, you will have tinnitus and all that. Don't forget the contralateral venous drainage, because sometimes fistula will be on right side, but patient drainage, venous drainage will be on contralateral side, and he will present for all the symptoms on the opposite side. So contralateral venous drainage also is possible, and you have to think about that. And clinical features may not reflect which type of fistula you are dealing, that you remember. Now, for example, you see this boy, severe chemosis, proptosis, ptosis, he's not ophthalmoplegia, he's not able to open the eye, vision will be also questionable. This is a type A, and complete anterior venous drainage. There is nothing draining posteriorly. This boy is also post-traumatic only, but fortunately or unfortunately, he's draining completely posteriorly. So he has very, very minimal chemosis, proptosis. So you will think that, oh, maybe this boy is having indirect fistula, but no, this was also post-traumatic, but all the drainage was on the posterior aspect. This is very minimal chemosis, there is hardly any proptosis, mild medial rectus palsy or something, but this was a type B fistula. So clinical features do not correlate with patient's fistula type. The radiological evaluation, the diagnosis is clinical, and ophthalmologists have to think of it. Means CCF presenting in radiology or interventional radiology groups is not enough. It has to go to the ophthalmology group because they have to think about it. And digital subtraction angiography is obviously gold standard, because only that can tell you what type of fistula you are dealing with, what type of venous drainage we have, and how you are going to treat it. CT and MRI can just establish the degree of associated brain injury. But mind you that even in post-traumatic cases, even if patient has got a massive head injury, they usually never present with CCF symptoms immediately. It always takes some 6 to 8 weeks or something like that for them to start developing those symptoms, and comparatively they are minor compared to the rest of the brain injury, so they take a back seat. Patient gets cleared of all the other things, and then only he comes to you for treatment of CCF. Now, when you do DSA, what are we trying to see? First, you want to identify the type, whether A, B, C, or D. You want to see the size and location of the fistula, that how big it is and how is the venous drainage of the cavernous sinus. You want to see if there are associated vascular injuries. I'll show you one case where we had post-traumatic, means it was a gunshot injury in an African child. So obviously he had torn cavernous ICA, but at the same time there was a dissection also in the cervical ICA. So associated injuries also we should see. And best is that you have to study the cross circulation of circle of Willis, because sometimes if artery is completely torn or if it is not salvageable, you may end up in occluding the internal carotid artery. Now, these are the different treatment modalities for the treatment of CCF. One is our standard that, oh, sorry, it went back. Oh, for me it is going, oh, okay. So, first thing is the commonest thing what we perform nowadays is the transcatheter coil embolization via either arterial or venous route, depending on the type of fistula. Previously, there were balloons available, gold valve balloons from Nycomed company. They were detachable balloons which we used to use on either coaxial or detachable balloon, magic BD it used to be called, balloon detachment catheter. And they used to do a good job. I'll just show you one case. But they went out of market and we landed up with these expensive embolization things of coils. Sometimes, as I told you, occlusion also you have to do. The important thing is, I want to draw your attention is that all CCFs do not need your interventional treatment. This we embarked upon because most of the patients who used to come with indirect fistulas used to be so poor that they used to hardly have money for getting angiogram done. Then seeing them and leaving them without any treatment, we used to feel bad. So we started this intermittent manual carotid compression maneuver, and I will show you that we have published papers in Orbit, that is an international journal, where we have such good results that most of the indirect fistulas, unless patient asks for, I do give a trial for at least 6 to 8 weeks. For that, their symptoms come down and patients do very well, and we don't have to do the procedure. Spontaneous closure of indirect fistulas is known to happen. I have seen only one in last 30 years, only once, but it has happened. Now I'll just go different case so that it's easier for you to drive the point home. This was a 28-year-old boy with a two-wheeler accident, mandibular injury, which was all wiring done and all. And finally, he landed up with us with that photo which I had shown you, severe chemosis, proptosis of the left eye, and complete ophthalmoplegia. But his vision was intact. And this was his picture, and you can see here, this is the rent in the internal carotid artery and anterior and posterior venous drainage. So this is that gold valve balloon, which we used to mount on the catheter, inflate it with the contrast, and then when you reach the desired position, you inflate it with contrast fully and keep checking that rent is closed, but the artery is patent. And then when you are happy about that, you detach the balloon. So this is how I have detached the balloon here. You can see the artery is patent, fistula has gone, intracranial circulation is also feeling better. So our patient gets cured in even less than ₹1,00,000, even in that times. But now the balloons have gone out of market. The drawback of these balloons used to be, if that balloon gets little deflated after your detachment, the fistula will reopen. If it come down. When he came after 6 weeks, you can see minimal chemosis is there and lateral rectus palsy is remaining. After 3 months when he came, you could not even make out where his fistula was. So very rewarding procedure psychologically also for patient. This was a truck driver from Nepal and had two-wheeler accident, head injury, and developed mild proptosis of the right eye with tinnitus in right ear. What I want you to see is that why tinnitus? Because inferior petrosal sinus is the drainage and contralateral, but there is no anterior venous drainage. You can see here there is only contralateral and posterior venous drainage. So this was little simple because we could see the rent there, go inside, and with this microcatheter coils have been deposited. he luckily did not need too many coils, and he's cured. So by coil embolization, this is transarterial coil embolization. Now coming to the third case, this was a 1-year-old child. While playing in the house, his wall-mounted TV fell on his head, and he developed head injury, and then he developed CCF and a growing fracture of the occipital region. So, of course, he had chemosis proptosis also. But when we did the angiogram, we understood the arteries torn completely. There is nothing to salvage here. Already his right side is completely supplied by the left side. No cross compression was necessary. This is a spontaneous filling in the circle of Willis. So he needed huge amount of coils to close the rent, to close little the venous side also. Almost 16 to 17 coils were used, and you can see ICA has gone. Actually, he was 1 year when we did the procedure. I think it was somewhere in 2000s. And recently he came to see me also, in the grown-up boy going to the college and all that. He's doing well. This was the boy I was mentioning, 18-year-old boy with gunshot injury from Nigeria. And he developed our symptoms, chemosis, proptosis, double vision in the left eye. And he also had a carotid dissection. So in him, what happened was, we could see the rent. The rent is seen very clearly. And this is the vein which is going like this and mainly going anteriorly, superior ophthalmic vein. So transarterially we went. And you can see here, the coils are here. But they were not enough. It was just swallowing the coils. So we understood we have to do something different. So we placed a balloon here in the internal carotid artery in the cavernous segment and injected. That time fill was available from microvention. So fill, that material we injected. And you can see here complete cure, that this small dot is remaining, but rest everything has gone. Then while coming out, we did put the wall stent in the carotid dissection also to take care of the dissection. Now this is different. This is a 29-year-old software engineer who developed all ophthalmological symptoms, including diplopia, but he had mild tinnitus also in the left ear. There was no history of trauma, infection, anything. It just started by itself. This was a typical type D CCF. You can see external carotid angiogram showing so much of filling of CCF, but luckily excellent inferior petrosal sinus draining into IJV. This was supply from internal carotid artery, bizarre, vague, like a smoke, but it is supplying. So now here, it becomes a classical dural AV fistula to embolize. Now, whenever you come with indirect CCF treatment, more time we have to spend in understanding the angioarchitecture, discussing what are the venous pathways and what is our plan for it. So here you can see we decided we will go through the venous route, and you can see guiding catheter in the IJV, but here petrosinus was open, so there was highway. There was no need to struggle to get into that. So through inferior petrosal sinus, you can see the microcatheter has already reached cavernous sinus. So we put multiple coils up to inferior petrosal sinus, and patient was cured. This is some other patient's picture, but same indirect CCF. What I want to drive a point is that looking at this, we will always think it is a post-traumatic, but it is not. This was also indirect CCF. Post-embolization, after 6 weeks, it was looking like this. Now, this was 50-year-old bank officer, and as I told you, I did try intermittent carotid compression maneuver on this patient. And it was reducing a little, but that irritation of the eye was killing him completely. He said, I'm not able to concentrate on work. So after discussing, after 6 to 8 weeks of trying the intermittent manual carotid compression, we took him up for embolization. Now you see here, he doesn't have a good petrosal sinus, but we all know that we can probe by thermowire into the petrosal sinus, and many times it gives us the pathway. So that's what we tried. IJV guiding catheter is there, and with thermowire we are probing. We went up to here. You can see the microcatheter tip. But this is that kitne paas, kitne dur situation, that we are here, but we are not able to enter the cavernous sinus at all. So this was another route where you can see the anterior facial vein, which is going into the cavernous sinus. But this stenosis was little troublesome, but we didn't have a choice. We had to go through this, and it was successful. You can see like this, it went. Finally, we reached there. coiled it completely, and patient was cured. Now, next patient has a short history of rapidly progressing chemosis proptosis on the right side with double vision, pain, lack of sleep, lateral rectus palsy, and this was an indirect CCF. But the moment he came to know that there is something abnormal in his brain, the patient was completely worked up, and he said, I don't want this conservative management trial and all, I want embolization directly. So we had to take him up for embolization. Oh. Okay, sorry. This is the diagnostic angiogram. You can see that this connection is not seen very well, and here you can see superior ophthalmic vein, which is dividing into two other veins, and that is draining down into the retromandibular vein and then into the external jugular vein. So here you see very bad venous pathway. And though it looks little okay, the venous valves always cause little problem sometimes in going up. So we also struggled a lot to keep my guiding catheter stable here, but we could not. We just could not keep the guiding catheter stable and maneuver the microcatheter. So we decided, okay, let's start probing the IPS. We started probing the IPS because it is the shortest route to the cavernous sinus from IJV. It's very safe, doesn't cause any problem. But it was not successful. Then we came to venous approach 2, that is the retromandibular vein and like this, and very long tortuous course, like this. But it was unsuccessful. So finally, we tried through left cavernous sinus, that whether we can go through intercavernous communication. Even that did not work. So we thought whether we can puncture superior ophthalmic vein directly. Even that was not possible because it was dividing into two. And this stenosis was troublesome because though we managed to come up to here through the retromandibular vein, we could never cross this. Like this, you can see here. We have reached up to here, but we just could not cross that thing. It did not allow. So it was the end of venous options. We tried IPS, ipsilateral, contralateral, retromandibular vein, anterior facial vein, everything, but we just could not go. But why we were struggling so much? Because venous axis is safe. We are not worried about these cranial nerve pulses in venous axis. So now we started probing into internal maxillary artery axis. You can see internal maxillary artery, and this is the most promising feeder, which is going up. Okay, and then there is a communic fistula, at arteriovenous malformation, and it is draining here. So we did this microcatheter injection, as Dr. Ajay was telling, and we knew that yes, we are in the malformation and fistula is, vein is filling. So what we did was we used headway DO catheter, microcatheter for pressure cooker technique. So headway DO was used. So that, why pressure cooker techniques? Because if we block the feeder proximally and we are going to use the balloon in the cavernous sinus, cavernous segment of ICA, whatever glue or whatever squid we are injecting is going to enter into the desired place, that is vascular malformation. It won't fly here and there. So that is why we did pressure cooker. You can see these are the coils used for pressure cooker. This is the balloon in the internal carotid artery cavernous segment. Septal balloon was there. And this is the embolic material injected. Post-embolization, you can see so much material is here, but at the same time, you can see patient is completely cured. No fistula is seen, but it was a big struggle. So the procedure was extremely prolonged because of the difficult venous access. It took almost 4.5 hours. We kept on trying for venous access because it is safe, as I told you. Arterial access through the dural branch of internal maxillary artery was our last choice, and it did work. But we have to take care that we have to keep balloon in the cavernous segment of ICA to avoid reflux of material into ICA and have a major stroke. So pressure cooker technique and balloon helped guiding squid in the right direction. So this is how the patient came with presentation. This is how he was after some 4 to 6 weeks. And this was at 8 weeks, that almost all other things have gone. The lateral rectus palsy I have seen always takes a long time to recover. Now coming to some indirect CCFs and different type of treatment. So this lady came with mild symptoms, but she was type D, caroticocavernous fistula with venous drainage into contralateral sinus. So you can see here, the fistula is on the left side, the symptoms are on the right side, just to drive the point that contralateral drainage happens. She underwent intermittent manual carotid compression, which gave her complete cure. So this is our paper, which got published in Orbit, and where good number of cases are there. We have 44 patients, and of that, some were lost, 5 were lost, and 39 patients, and 89.7% cases were cured with no major complications. It is just with that. And we are so used to it that I can tell you in what sequence their symptoms go. The first thing which goes is the irritation of the eye. Then watering of the eye stops. After that, slowly the proptosis and chemosis starts coming down, to the extent that finally they say, when I get up in the morning, only the eye looks red and little bulging. After that, whole day I look normal. And then that also settles fast. Last thing to settle is the lateral or medial rectus palsy. Usually by 3 months, most of the patients are completely cured by 3 months. And this is our routine, means this is not a surprise for us at all. They really, and even people who are coming from areas where we think literacy is not much, all of them learn very well. We take a lot of practice from them before going, how to do intermittent manual carotid compression, how to look at the watch, 30 seconds, stop 30 seconds and all that, and they do extremely well. Now, this next case I will show you, he was 80 plus, he was 84, 85, had so many comorbidities like cardiac failure, renal failure, this, that and all. He used to come for regular dialysis, and suddenly they noticed that he's having chemosis and proptosis of the right eye. So luckily, because he was in Chennai itself, he got diagnosed and it was CCF. So I did the angiogram for him. So this was his picture on presentation. So it was a right-sided indirect CCF. Now with such an old man with comorbidities, I told him that you do intermittent manual carotid compression, he will become all right. What happened? He started doing the carotid compression and he became like this. So I told him, don't worry, this is SOV thrombosis which has happened because of the compression. We will treat this thrombosis and he will become all right. But unfortunately, except him, everybody in the family was doctor. All the children, grandchildren, their spouses, everybody was doctor. So they started jumping up and down. No, we don't want this conservative. Let's go for embolization. Getting his anesthesia clearance and fitness was so difficult. But we did manage. We took the patient for the treatment. Angiogram was normal. This was just SOV thrombosis, which we treated as usual with heparin, cameral fort, and steroids and all those things. And he became all right. Look at his after cure, this is his picture. He happened to be actually the granduncle of our cardiologist and skin specialist. So this is what is his picture. So for this also we did present a paper. It's not coming there. It's not moving. Now something happened. Yeah. Superior ophthalmic vein thrombosis in the post-manual carotid compression patients for indirect caroticocavernous fistula, because we observed it in 5 patients. First time when we saw, we were a little stunned. I said, oh my God, what this happened? But then I did MRI for those patients and we understood that the SOV is having complete thrombosis. So you just treat that thrombosis. Only thing, when we are giving steroids, we have to check if patient is diabetic or not and then adjust the dose accordingly. Otherwise, they respond beautifully for heparin and steroids and chimeral fort and anti-inflammatory measures, and they do very well. We had 5 patients and all 5 of them got cured with medical treatment. They were cured of CCF also, they were cured of SOV thrombosis also, without any stigma left behind. Now, this was the only lucky lady in my experience. She was having left-sided redness of the eye, tinnitus in the left ear, And same thing I told her son, that let her, she had very mild symptoms. I said, let her do this carotid compression, she will become all right. But they were coming from one of those government agencies where their expenditure is covered by the government, Division of Atomic Energy. So they said, no, we want treatment immediately. So within 2 days, she was, after anesthesia, fitness and all, she was posted for the treatment and she had complete cure. This was her picture. And this is just 2 days after that, angiogram was done, and there was nothing to do for this patient also. So she's the only patient, but that's what they say in literature, spontaneous cure after angiogram can happen, and she was the only lucky one. So in summary, I would like to say that DSA is a must to diagnose CCF. Even if they see on MRI, CT angiogram, or clinically or whatever, without angiogram, there is no go for CCF diagnosis. We have to remember that only type A is the fistula, real fistula, and rest all of them are dural arteriovenous malformations of cavernous sinus region. The clinical features thoroughly depend on venous drainage. They do not depend on etiology or type of the fistula. Venous drainage dictates how the fistula presents or patient presents. There are multiple treatment options available, and we have to choose the treatment option depending on the angioarchitecture of the disease. And this is the only disease which can be treated only by interventional radiologists. There is nobody else who can treat caroticocavernous fistula. Patients have to be treated by us only. And this is the only disease where patient immediately sees the change in him that he has got cured. And they are very grateful to you for that. Thank you so much for your patient hearing.
Thank you, madam. Good presentation. Definitely, type A is the most rewarding neurovascular intervention procedure. Any comments, 1 or 2 comments from audience?
Thank you, ma'am. Looks like you have to teach us the carotid compression now. The whole presentation, I thought that is the most important thing because that can cure many.
Actually,
how do you just teach them, or how do you want us to the patients?
I'll tell you. Actually, previously, whenever I used to say this in our forums, informally, they used to say, you have to present this, you have to present this. So now we have published it also. Now at least everybody will accept. And why make patient undergo such a huge procedure, expenditure, and really power? Most of the times, those poor people cannot even afford angiogram. To tell them that budget of 4 lakhs and 5 lakhs and 6 lakhs, and it looks absurd, absolutely absurd. And you know that they are not going to do anything about it. Might as well try this. Like that we started and it worked so well.
So please tell us the protocol, how you advise them, what kind of compression and timing, duration and all.
You want me to tell from stage?
Yeah, in 2 minutes.
Okay. We tell them opposite hand, opposite side, like right hand, left side. First of all, it is easy to do. Secondly, if they get any untoward thing, the hand will automatically lose the power. So we make this has to be done either in lying down position or sitting, like that we tell. Then you make them understand that it takes little time for them to understand where is the pulsation. So first I teach them on their hand that this is called pulsation. We know, they don't know. So then I make them use their 2-3 fingers and I tell them to keep here. Ask them to look at the watch or count in the mind 1 to 30. So first 30 counts, you press. Next 30 counts, you release, but don't take out your hand because again they will take time to search. So release, just stay there. Again press, release. Like that in 1 hour you do 6-7 times continuously. Take rest. Don't do anything after that. Again next hour. So in a day, if this set of 6-7 times, if you do 4-5 times, it's enough. And they immediately start. First is that watering of the eye stops and irritation stops. And they are so happy about it because they are the most irritating symptoms. Chemosis and proptosis we see, they don't see themselves, so they don't experience it. So like that we ask them
30 seconds of compression,
30
release
seconds
but
you
hold,
release.
Release but hold again 30 seconds.
Like that 5-6 times if they do in 1 hour, that same
Maybe
time continuously.
4 to 5 times.
I'd like that 4 or 5 times a day. So it becomes like maybe 30-35 times in a day. That is enough. And then most of them are outstation patients. So they keep follow up on the WhatsApp. They keep sending photos of their eye on the WhatsApp and we keep following them up.
Thank you so much. Thank you.
Last comment. Any comment?
Yeah. Yes, sir.
Last comment.
It was a really nice presentation. I'm Vikas Mishra from Bhubaneswar. I just wanted to know in the superior ophthalmic vein thrombosis, you had said about the steroid. how long you give? Is it a topical steroid or the just systemic steroid that you give? And what are the doses that you follow? And what is the exact mechanism steroid works in ophthalmic?
Actually, it's not topical steroid. We give them tablets to eat. And usually initially we give little higher dose, like 4 milligram tablets 4 times a day, or depending on how much symptoms are, or 3 times a day, like that. And then taper.
Dexamethasone 4 milligram 4 times a day, then taper off.
And then taper off. And heparin also, first we give subcutaneous heparin for first 4-5 days or something like that. And after that we change to warfarin also for some time. And once it is over, then we stop it. Caprol Fort also helps in reducing the inflammation. So that also does very well.
Steroid, you give it for how long?
Steroids, it depends on the symptoms, but usually for 15 days at least we have to give so that we get cured.
Thank you.
Just a quick comment.
Yeah.
In 2015, I had a complication in embolization of direct CC fistula with the film. It was a migration of the embolic material to the MCA territory, and for me it was first time, and I have seen the fill is becoming larger and it's blocking MCA, and comparing with the other liquid embolic, it's not possible to retrieve with solitaire. And it was my first and last experience with fill, and I have seen several cases from European colleagues with the same final result with the fill migration. That's why I stopped to use fill for the direct CC fistula, only tantalum-based like squid, Menox and Onyx.
Yes. Thank you. Thank you.
Thank you. Next talk is by Dr. Bharat Sitaram.
Thank you so
Complex.
much, Swati ma'am, for sharing your experiences with us. Now, before stepping into the next topic, I would like to, I have a request. Because Silas sir has left to catch a flight, I would like to invite Dr. Dalai sir to be as a chairperson as well. Thank you. Welcome, sir.
That presentation is... Yeah. From this laptop, is it possible?
Yeah.
Please open. I am happy to be here. Thank you, Siba sir, for calling me, giving me a chance to show few of my cases. My topic is actually complex cases, but after listening to Ajay sir and Swati ma'am's talk, I think my topic will be easy cases of dural AVF. So let's go through these easy cases. Where do I point this? But it's not going forward. Okay. So we start with the first case, middle-aged man. He presented with chronic headache, and his MRI showed a dilated frontal cortical vein with remote hemorrhage. So there is some hemosiderin stain over here, and you see there is this cortical vein is little abnormal. There is some gliosis also there. We did the angiogram. It's a ethmoidal dural AVF. You already seen how they have feeders from the ophthalmic artery, ethmoidal branches. And you already seen from Professor Ajay that how he treated with ophthalmic artery, and he treated them with the middle meningeal artery. So when we were searching, we found that there is this middle meningeal artery which is reforming via this anterior falcine artery is supplying the fistula. So definitely that is a preferred route, but the only problem is it's very, very tortuous. You see that we all have been doing intervention, and we know there are some areas like probably this may be a painful area to negotiate, and of course, these bends can be a bit difficult. So one trick is to give a nice pigtail kind of a loop to your wire. Wire is preferred, wire is usually hybrid wire, 008. So that is what we have used here. So our plan is 6 French chaperone guide in right ECA, marathon microcatheter and hybrid 008 wire combination through right MMA up to the fistula, Onyx 8 agent. I don't know how well it is projected, but we have already reached deep into the fistula, and these are the feeders. That's the anterior falcine artery, that is the cortical vein which we were supposed to block, and the fistula is cured. So whenever possible, we should try and search for this alternative pathway which are much safer and preferably sometime easier too. So little discussion, already discussed in detail, that these are actually direct fistula to the cortical veins, because in the anterior most part the SSS is not well formed. It can be technically challenging because approach is long and usually tortuous. Catheter may not be long enough to reach anterior cranial fossa via femoral approach, and navigation is sometimes not straightforward. We can use some distal access catheter like CAT5 and all. But the one important thing here is to remember that this fistula is also treatable by surgery. The ethmoidal dural AVF is one such fistula which can be very well treated by surgery, and always explore this option if there is no straightforward endovascular procedure available. However, surgeries are not altogether benign. Most cases require opening of the frontal paranasal sinus, which can lead to a number of issues, not usually as bad as blindness, but not pleasant either. There is another case I want to show here, that when you cannot reach via transarterial route, you can reach transvenous, and if transvenous is occluded or sequestrated, you can always recanalize the sinus. So this is a 35-year-old man. He presented with left intracerebral hematoma, DSSO dural AVF of the sequestrated sinus, refluxing into the cortical vein. So just to show that he presented with this bleed. And this is cone beam CT, which shows that there is a fistula over here. This is the part of the sequestrated sinus. It is refluxing into this vein, running along the cranial base, and then it is refluxing into the sylvian vein. So these are the different feeders from posterior auricular and occipital, and a tiny bit here from the middle meningeal also. I did try from these transarterial route, but it was quite difficult to go through the occipital artery branches via these tiny transosseous perforators, and then after a while it stopped going into the artery and it was going into these scalp veins, and it was not penetrating inside into the sinus. So I did not achieve much. The fistula was very much there, and the onyx was all gone inside the scalp veins. I lost the budget which I had quoted for the patient. I said, okay, it is going to cost this much, and then it's over. Like you call itna paisa mein itna hi milega, like that. So when you get tired, you call it a day and fight the battle some other day with a new or better plan. So this is what we achieved, after so much. Didn't achieve much, but you always achieve one thing. Whenever you fail, at least next time you start with experience. So I plan to recanalize this sinus. went to the occluded sinus here. This is the part which is occluded. With a J teromo wire, angle loop, I crossed into the sinus, and I reached inside the sinus here with the microcatheter. This is the place. So then I came down to a very, very cheap option. Like I put some Nestor coils over here through Prograde and some NBCA glue reflexed back into the perforate, into the feeders, and the fistula is gone. So the learning point here is penetration of onyx through transosseous feeder sometimes it is difficult, time consuming and expensive, and with proper planning, recanalization of occluded sinus can be quicker and less expensive option. We already discussed direct and indirect CCF. This is a small animation made by my mentor, Dr. Matthew Cherian, that this is how these fistulas are blocked, right? So we'll directly go to the case. We all know how the IPS goes from the IJV via the jugular foramen into the cavernous sinus. Very important to know this anatomy for recanalization. Now this case is just to show that if you are lucky, you have the IPS open for you. You can see the fistula here. You see that it is mostly in the posterior part, and this part is good to be occluded. And this is just to show that this is how we go and this is how you occlude. Better to occlude the foot of SOV because sometimes it's very difficult to go back and do the procedure. But what I want to share here is drilling of IPS. How to drill an occluded IPS. When Swati ma'am was presenting, she said, we drill the IPS. I thought, okay, my presentation is over here, but she couldn't drill in two. So I'll share my experience here. I learned it in Link Asia. That is how they have been doing. So this is the patient. She presented with a little bit redness of the eye, ophthalmological evaluation and cross-sectional imaging, suspected left side carotico-cavernous fistula. We all know how it looks. IPS is occluded here, cavernous sinus refluxing into the facial vein. So what would be your preferred approach? If you are comfortable drilling IPS, you drill the IPS first, or if you fail, take the facial vein. Some more images. Cone beam CT, just to show that the vein is right here, to show my thinking plan, what I'm going to do. And I did that. And I dissected the vein, and that discussion is over, that this is gone. So you have to try another way. So we all know that it comes from the pars nervosa, anteromedial and smaller part, Contrary to, though it is vascular, but it comes from pars nervosa. Very important to understand that. So IPS is located in pars nervosa. We can either take a jugular foramen view to guide us. There's a transoral view on an X-ray, and you tilt the head a little bit. Or you can take help of cone beam CT. Like all of us are having cone beam CT in our angio suite, and you can use that. A standard way to do it, short sheath in the IJV. So in that case, if you glue the catheter, you can just cut it in the IJV and leave it there. MPA-shaped diagnostic catheter, 035 straight tip hydrophilic guide wire, microcatheter, microwire, detachable coils, and liquid embolic agent. This is all you need. You can use the cone beam CT to see that the wire is going in this canal, which is harboring pars nervosa, right? You can use the cone beam CT, and this is how we do it. Like you take the roadmap from the arterial route, and you probe here. So you have to stabilize the catheter in a very perilous vein. Sometimes it is difficult, so you try and fix it properly, and then just drill. Can you see anything happening there? You can't see because it doesn't happen that easy. It takes a little time. But you will see. Now you can see the movement that I'm trying to drill it. And with one pop, it will go. Like you'll feel that, okay, job done. So it's gone, right? You can see that this is the kitna dur, kitna pass moment, and then it goes. So when it goes, you pull out the wire under the road map, you know this is the way you had gone, and you have to go again, just like Mount Everest, you have to climb again and again. Everybody has to climb. So you go through this, take a microcatheter, take the wire, and this feeling is beautiful. Suddenly this pop is the one which gives you the happiness that, okay, now I have something to do. And then the user procedure is the same, like you coil everything possible because you've taken, half a day to reach there. So you coil everything. And that shows that the fistula is now cured. Sometimes you can add liquid embolic agent also a little bit. And I learned from my experience and also ma'am's experience that, the redness doesn't go right away. It takes a little time, especially in these indirect fistulas. But the itching goes, the discomfort goes. That is the one to go first. And later on, it comes to normal. This is the bleed which happened because of the facial vein dissection, which is our complication. So infrapetrosa sinus recanalization, helpful technique to reach cavernous sinus. Indirect CCF, knowledge of anatomy is vital for planning and execution. And the case is testimony to the fact that a technique learned at the live conferences can be replicated. If they are doing, you can also do it. Thank you so much. This is the demon we have to fight every day.
Thank you, Bharat, for showing some wonderful technique to recanalize those IPS. What is your opinion on doing pressure cooker on these occluded sinus in the case number 2, dural fistula?
In occluding these sinuses?
If there is a occluded sinus or partially occluded sinus with the fistula, so you try transarterially and the onyx.
Yeah, first approach is always transarterial. If you fail,
do you have any experience of doing transarterial pressure cooker technique for DAVFs?
No, I have not done, but then, with over time I've realized that if you're going through occipital artery, then it's better to do pressure cooker or use a balloon.
Right. So can we go ahead with the next talk? May I invite upon? Thank you, Bharat. Thank you. We have Professor Shyam Kumar, the head of the Department of Radiology and Intervention in the prestigious CMC Vellore. So when we started in Orissa doing MBBS and then started practicing in Kolkata briefly, so every patient used to go to Vellore. Only some Vellore failure cases used to come. IRIA yesterday, and he could make some time for us. Thank you, sir.
Thanks, Dr. Shiva, for your kind introduction. And it's really amazing how you kept everything organized. And it's really amazing. And thanks for that. And thanks for including me in this great event. So I kept my CV in case if needed for backup. This is a short presentation on balloon-assisted cerebral venous sinus thrombectomy. I have specified this technique because this is what we are practicing for the last few years after trying various other things. So these are some of the initial points about a CVT, and it is a serious condition, and if they are not treated in such a situation, they can manifest as a chronic problem, and some of them may come as dural sinus fistula, which you have seen in the previous 3 talks. And overall dependency rate in this is about 15%. So the main approach for treating this dural sinus thrombosis is based on MRI, MRV, and go for medical management. And I have written surgical embolectomy in brackets because I don't think anybody is practicing embolectomy now. But there is a role for craniotomy for the patients who have severe intracranial hypertension. Endovascular, I again put pharmacological within the brackets because nowadays we are not practicing it much, whereas we are doing more of mechanical thrombectomy. We talk a lot for arterial side mechanical thrombectomy. Venous side is less discussed, and it is different from arterial side mechanical thrombectomy. These are the few points I would like to highlight. One is venous side, the flow is less, and the volume of the thrombus is much higher compared to the arterial side. Hemorrhages are more common, and recanalization is not dramatic. We do not see sudden antegrade flow like we see on the arterial side. Some more points. It's a retrograde approach to the veins. We have somehow, we are fortunate to have longer window period. There could be some antegrade emboli from the venous side as we manipulate. Can it be ignored? What about hardware available for dural sinus thrombectomy? We are modifying some of the arterial side mechanical thrombectomy devices for the venous side. I'll start with a case scenario. This is a young lady who presented with the acute onset of headache for a few days, and she had some sensory deficits and also had seizures. And she had upper limb and lower limb weakness. And these are the representative MRI images, what we are having here. We can see the clot in the superior sagittal sinus. And there is also involvement of parenchyma, and there is involvement of straight sinus. You do not see the straight sinus here. Extensive filling defects along the superior sagittal sinus. This patient was treated medically first, and she had persistent symptoms, and she was taken for mechanical thrombectomy. With this case, I will show how we do it. All these procedures we do under general anesthesia. We use biplane for better visibility. Initially, we take a transrectal access. We keep it small, like a 4 French catheter. This is just to see how is the arterial filling, how is the parenchymal phase, and how we see the sinuses. Then jugular venous access, we take directly. We do not go transfemoral venous access. And this is done always under ultrasound access because there is a lot of variation in the internal jugular venous anatomy. Here you can see the carotid artery and internal jugular vein, which is easily compressible. Most often, we see jugular veins are patent, though there is extensive dural sinus thrombosis. And we place a 5 French catheter. Then we take an arterial run like this and see the amount of burden on the venous dural sinus side, which will be seen as a filling defect. After that, through the venous access, we take a 4 French catheter, and we take this within this 4 French catheter, we take a 3 French prograde catheter. So with prograde, we manipulate along the sinus, and we reach the anterior part of superior sagittal sinus. So once we reach there, we take a small caliber balloon, like a 4 mm balloon, and we inflate the balloon along the sinus. Here we have taken a relatively long balloon to reduce the amount of radiation. And we change the biplane according to suitability, wherever we see the sinus, that part of the sinus in better profile. After that, we take a Fogarty catheter. So I just would like to tell about Fogarty catheter. It comes in various sizes. The one which we take here is the 4 French, and is 80 centimeters long. The actual indication for Fogarty catheter is for surgical embolectomy from femoral artery or from popliteal artery. It is not meant for this particular procedure. This is an off-label procedure, and we take this through a 5 French catheter, 5 French sheath. Though it's a 4 French catheter, it doesn't go through 4 French, so we need to take a 5 French sheath. Its length is short, it's only 80 centimeter. This can be done only if you are taking a transjugular access. From femoral venous access, we cannot reach. So once we prepare this balloon, it's very easy to prepare the balloon. It is a soft balloon. We take the balloon inside along an exchange length wire, and we take a blank roadmap so that when we inflate this balloon and pull out, we'll know how much is the resistance we get. And we make sure that it is not too tight. If it is too tight, we deflate this balloon partly, and we start pulling it down. As we are pulling it down along the superior sagittal sinus, we keep a lateral fluoro predominantly. And once we reach the sigmoid sinus, we take transverse sinus and sigmoid sinus. We change the plane in such a way that we see it in the longest profile. Whereas if there is involvement of straight sinus, we pass a wire and we just balloon plast this area. We do not use Fogarty balloon in the straight sinus because the straight sinus is not having any bony attachment. So pulling a balloon in this area can be dangerous. We have not tried for any patient. So once we do this, through the arterial axis, we take one more angiogram towards the end and see how much is the recanalization. So if you see here, there is some amount of recanalization, what we grade as partial recanalization, and we look for patient's clinical recovery. The first response what we see is the clinical response to these patients, and we follow up over a period of time. So this is a follow-up MR imaging over a period of 3 months, and this is how we see recanalization during the follow-up. So you can see a good recanalization of the superior sagittal sinus, and even straight sinus is visible. I would like to highlight some of the points here. First, we have to study the MRI well. How much is the parenchymal involvement and how much is the sinus involvement? If you see here, the superior sagittal sinus here, it has got a predominant commitment towards the right side. So when you see this kind of predominant commitment to one side, that is the side where we have to access the jugular vein, because that is a place where we can easily manipulate the catheters into the sagittal sinus. Most often, the superior sagittal sinus is deviated to the right side. Regarding size of the sinus, it will be about a few millimeters, 6 or 7 millimeters in an adult. And in addition to the size measurement, what we see, we have to adjust the balloon while pulling it down. On the arterial side, we take a 4 French catheter. Based on the MRI, what we do is, whichever is the dominant side, if there is an asymmetry, whichever side is dominant, whichever side the A1 is bigger, that side we do angiogram so that we can see better opacification of the sinuses. Internal jugular venous access is always under ultrasound guidance because the anatomical relation of the IJV to carotid artery is so close, and sometimes the internal jugular vein can be deeper also. So don't do blind puncture of the sinus at any time. If there is no easy approach from the internal jugular vein to the occluded sinus in the transverse sinus or the straight sinus, in such situation we have punctured the contralateral IJV and then we have manipulated the catheter. So in few cases, you may reach the superior sagittal sinus from the right side, whereas to reach the straight sinus, we may have to go from the contralateral side. Whereas the case what I have demonstrated now, both we could access from the right side. One of my fellows asked once, what happens to these thrombus? Because when we just drag them and leave into the venous system, where do they go? The answer is simple. They all go to the pulmonary arterial bed. Remember, the pulmonary arterial bed is having a huge capacity compared to the thrombus load what we have in the dural sinus. It is minuscule for the pulmonary arterial bed. So how do we say this? I'm just translating our experience from dialysis fistula repair, where the thrombus load compared to this will be 3 times or 5 times more than this. So none of them develop pulmonary arterial embolism, which is clinically manifested. So what we do is we keep a pulse oximeter and keep monitoring them and see if there is any variation. Whereas in the straight sinus, I would like to highlight 2 points. One is keep the viral loop so that there is no accidental chance of perforation. Secondly, we underdilate it. Here, if you see, we have just kept as a 2 millimeter balloon. The straight sinus could be somewhere up to 3 millimeters or 4 millimeters in the size. Then here we have adapted some of the techniques what we use in the body territory. So this is basically an off-label technique. So we use a 5F short sheath in the internojugular vein. We keep it in such a way that the sheath doesn't cross the skull base. We use a cobra catheter. Within that, we use a 3 French prograde catheter, and that is suitable for an overnight wire. Fogarty, as I mentioned, it's only 80 centimeters in length, and it has to go from jugular vein only. First, what we see is the clinical improvement, more than the radiological improvement, and how it works. This basically works as a combination. What we do is a facility for the natural anticoagulation and therapeutic anticoagulation to reach the sinuses better so that it helps the patient for recovery. Now, we have certain concerns. One is, are we providing adequate inflow? Because angiographically, we do not see instantaneous antegrade flow, but clinically, the patient show response. Are we going to damage the mechanical damage to the sinus wall, whether it's a short-term or long-term? What happens to the arachnoid villi which are present on the wall? But for this, we do not have any evidence. Even if you don't treat at all, the thrombus itself can damage the arachnoid villi. Can there be a problem with the materials what you used, and can there be pulmonary embolism? These are some of the points what we have learned after using Fogarty balloon. The duration what we take for doing this procedure is approximately 1 hour. Compared to the earlier techniques what we were using, it used to take for about 2 hours or more. The hardware what we use is minimal. The Fogarty balloon, what you use here, it costs about 4,000 rupees. The cost is approximately 1/3 overall. And the radiation, because we are overall doing this procedure for a shorter time, it is significantly lesser. Because the cost is less, there is a very low threshold for referring the patient for mechanical thrombectomy using this procedure. So we are able to provide the benefit to more and more patients. So our initial experience, we have published in a journal recently. It has come in the Stroke Journal, Vascular and Interventional Neurology. So in this, we have highlighted our experience over a period of 5 years using this particular technique. During this time, there were more than 500 patients of CVT which were presented to the hospital. Among these, about 50 plus patients underwent mechanical thrombectomy. If you see here, nearly 50% of these patients had already parenchymal hemorrhage. So parenchymal hemorrhage being there, it is not a contraindication, it is an indication. Our indications included, the commonest was clinical deterioration. This clinical deterioration is decided by the GCS scores. If the GCS score is coming down by more than 1 point, it is an indication for mechanical thrombectomy in this particular study. If there is involvement of the straight sinus, we kept the threshold lower. Instead of waiting for the patient to deteriorate, we took the patient for embolectomy earlier. If you see what I have highlighted in the green color, this is what we anticipated on table. So partial recanalization is what we see, and we don't anticipate a full recanalization of the sinus, and that is not required. After doing this, a small percentage of patients still required decompressive hemicraniectomy. We had one complication which I would like to mention. While pulling the Fogarty catheter, there was breakage of the Fogarty catheter and ripple in the sinus. So this we could snare and take it out from the patient's body. If you see the mortality rate in the hospital, it's about 5% overall. So this is much lesser compared to the mortality rate due to the CVT alone, which is in the range of about 20 to 30% based on several publications. So in our study, we don't have a control arm because once we started believing that this works well, so we have gone along with the medical management and mechanical thrombectomy whenever it is required. And all the cases what we have taken are the CVTs which are on the worst side, whereas the ones who are responding for mechanical thrombectomy, we have not taken. So we do not have ideal comparison for this. We also saw that younger patients responded well. The ones who did not have hemorrhagic infarction, they showed a quicker response. This is the MRS score at the time of discharge. At the time of discharge, we can see that patients who were self-dependent were about 65%. And as we waited, and within 1 year follow-up, you can see even more percentage of patients were self-dependent. So MRS score up to 2 is better, and they do not have dependency. So I just want to summarize saying that this is a technique which is easy to do, which takes lesser time, and it is safe. And the case where we saw breakage of Fogarty catheter, it happened in the beginning. After that, we were more careful, and the technique what we adopted after that procedure, after that particular patient, was to see and be more vigilant at the time of pulling the catheter. Whenever it's crucial, not well appreciated, go for biplane in that kind of situation. And always, we believe that it is part of the treatment. This alone is not the treatment. This goes along with the aggressive medical management. And always we look at the clinical response. That is the one which we appreciate first instead of radiological improvement. And finally, to say that it is cost-effective and perhaps more suitable in developing countries like us. Thank you for your attention.
Thank you, sir. So it has been a low-cost morning session. First, Swati ma'am said that no expensive embolization, just do carotid compression, you can get rid of CCF. Now, Shyam Kumar sir said no expensive trend retrievers, you just do a Fogarty and you can get rid of all these things. So that is fantastic. At least, in India, we can do all the cost-effective procedures very well. If there's any questions from the audience.
Sir, nice talk. I just want to know how quickly these patients improve, like in clinical settings.
The clinical response is same day.
Same day?
Same day.
Yeah.
Same day we see.
So that is pretty good,
Yes.
sir, because we have been thrombolizing these patients, catheter-directed thrombolysis.
Correct.
So first debulking with the ACE catheters, which is a thrombectomy catheter, same to the jugular route, and then put a perfusion catheter and lyse it, but you are not using any lytics.
We do not use any pharmacological agent in this. I should tell you the truth. When we used pharmacological agents, we saw some of these hemorrhages worsening, and we did not get much referral for the thrombolytic therapy. So that is the time we switched over to mechanical thrombectomy. When we started mechanical thrombectomy, I should mention the device what we used. It was a penumbra.
Yes, sir.
With penumbra we used, and we got a reasonably good result. And it was somewhat similar to this. Then subsequently, it was not available in the market for some time. So that's the time we switched over to the Fogarty balloon technique. So with this, we are finding very good success. That's how we monitored, and we are continuing with this technique.
That's amazing, sir, the same day response, because in thrombolysis also, I have done only some 14, 15 patients, and the response is usually after 36 hours or so. Because it takes the thrombus to lyse, at least 24 to 36 hours. So this is really quick and safer, I think. Thank you so much.
Yes. See, with this, we keep the threshold less, because we are not using any pharmacology agent. Even if the patient develops hemorrhage following our procedure, we know that it is not due to our criminal offense.
Yes, sir. And you monitor it intermittent check angio, DSA, or how you decide your endpoint, sir?
Yeah. Once we do this procedure, we look for a clinical response. If the patient is improving, we leave the patient like that. And after that, we monitor on the MRI. So before the patient is discharged, we do MRI. And if the patient is worsening after we do the procedure, we take the patient again for procedure after 1 or 2 days. And that time, again, the same steps are followed. In our publication, we have mentioned how many patients we re-intervened. I think about 6 or 7 out of 57 patients underwent re-procedure, whereas others, one-time procedure was adequate.
So do you leave the jugular sheath in situ for
No.
You remove
We
it
pull out the jugular sheath.
and do
Because
puncture
there are two
again.
reasons. One is puncture in the jugular axis, jugular vein is very easy. Secondly, the sheath what we require for jugular vein is only 5 French. So pulling it out is very easy. And in addition, there is no risk of hemorrhage because it's a venous puncture and we pull out.
And on table, how you decide your endpoint, sir? That, okay, now this is enough, like after 5 passes, 10 passes, you say,
Yes.
now I'm going to
Yes,
stop.
correct. We do about 3 to 5 passes. 3 to 5 passes. And we do not take any direct venogram in this. Whereas at the end of 3 to 5 passes, we do again a regular angiogram through transfemoral arterial access. So we keep this catheter in the common carotid artery. We connect a side-arm saline flush and keep it like that. So at the end, we do an angiogram and see how much is the recanalization. So if there is better antegrade flow in the venous space, we leave it like that.
Thank you so much, sir.
Yeah.
So during this procedure, do you remove some thrombus or you create a passage? Some thrombus comes out during this procedure or you create a passage?
No, we just create a passage. All these thrombus, whatever we remove, it goes into the SVC, right atrium, and finally ends in the pulmonary arterial bed. We don't pull out any of these thrombus.
No removing the thrombus, but creating a channel where the anticoagulations can work better.
Yes, anticoagulation will be continued. So it facilitates better anticoagulation, both natural as well as therapeutic anticoagulation.
Right, sir.
Thank you.
Thank you so much. So we have come to the end of the session. We are not going for a tea break because we are running late. We will move on to the next session.
Thank you so much to the esteemed speakers and chairpersons for the wonderful discussion. Now, before going on to the second set of topics, we'll break for some time for memento distribution and then we'll go further.
So we would like to call upon Dr. K. Satyavara Prasad, sir. Sir, we are calling you to the stage for memento presentation for the speakers. We would like to call Dr. Ajay Kumar, sir, to the stage to receive his memento. Thank you, Ajay sir. Now we would like Dr. Swati Halbe ma'am to receive her memento from Dr. K. Satyavara Prasad sir. Thank you, ma'am. Thank you, sir. Thank you, sir, for your time. Next, we would like to call upon Dr. Vijay Shekhar, sir, onto the stage. So we would like Dr. Vijay Shekhar, sir, to present the memento to Dr. Bharat Sitaram, sir. Yes, sir. Next, we would like to call upon Dr. Shyam Kumar, sir. Thank you, Vijay Shekhar, sir. Next, I would like to call upon Dr. G. Shivaram, sir. Yesterday, due to the time constraint, we could not present the memento to Dr. Sharat Kumar, sir. So, sir, we would like you to come onto the stage. And we would like to call Dr. Gunadhar Padi, sir, onto the stage, please. So we would like to ask Dr. Sivaram, sir, to remain on the stage. Dr. Dalai, sir, will now present a memento to Dr. Sivaram, sir. Dr. Dalai, sir. Next, we would like to call Dr. Vijay Shekhar, sir, onto the stage to receive his memento.
Well, we'll move further to the second set of topics. For that, I would like to invite Dr. Minjal sir, Dr. Manas Panigrahi sir, Dr. Sarat Kumar sir, Dr. K. Narsinga Rao sir to be on the stage as chairpersons. And I would like to call Dr. Azmi sir to share his thoughts about endovascular management of brain aneurysm.
Hello. Good morning, ladies and gentlemen. Thank you, Siba, for inviting me to this beautiful city with the excellent speakers sharing our experience in neurointervention. I learned a lot during this session. Now we are in the more expensive session, aneurysm using multiple device, coil, agentic like contour and also flow diverter. My topic today is on endovascular management of brain aneurysm using coil and adjustive device like stent and balloon. As you know that the ruptured aneurysm is the devastating condition. 1/3 of the patient may have died of this condition, and those who survive 1/3 have severe morbidity and mortality. However, in the past year, when the development of treatment using endovascular have developed, we continue to have better outcome and treat this aneurysm. And as you know that initially we treat the aneurysm during surgical management. However, as early as 1990s when they have detachable coil, we have changed our type of treatment more toward endovascular, and this is supported by ISNR trial that shows that endovascular treatment improve the relative risk of dependent and death about to 7.4% compared to surgical treatment in the 1 year. However, in the early stage of development, there's a lot of criticization because of this coil design and also the high rate of recurrence because of the complexity of the aneurysm itself, and also in early stage, the technology is not very good. But now, you see with all these things, we have changed more treatment of endovascular towards the aneurysm. And you can see here that the treatment, both ruptured and ruptured, have gone to more the endovascular kind of approach. However, the coiling itself can be very difficult because we encounter many types of the aneurysm of various size. But however, in the acute phase, the most important thing for us is to close the aneurysm and pack as much as possible, and we can always call the patient for the next session if we require to the procedure. And with this difficult type of aneurysm and also the shape, we have other devices to help us to get a cure rate of this aneurysm in the future. My topic today is more towards the coil and also the balloon and the stent, because the other will be given by other presenter, which include flow diverter by Dr. Ude and also contour and webs for the next speakers. So the challenges using the coil basically is when they encounter that the wide neck aneurysm and also very shallow aneurysm. So in this condition, we may need to require other adjunctive treatment devices like balloon. Balloon is initially is very good because it helps to prevent the coil from prolapsing to a permanent vessel, and also if we encounter ruptured, then we can always inflate the balloon. The balloon technology also evolved from many years. Initially, we have not very compliant balloon. It's good for sidewall. However, with the new balloon like Hyperform, Hyperglide, we can do more complex procedure, especially at the bifurcation aneurysm and the sidewall. You can see here how this very hyper-compliant balloon Eclipse can really invaginate to the aneurysm and can protect the sidewall if we encounter this complex wide neck ruptured aneurysm. So this is the video we can show. Play the video. Can we play the video? Then we can see how to play the video. Is this? Yes. Sorry. Okay. Next. Is it to play video? Yes. Okay. It's moving again. Can play the video? So this video, I want to show you how the compliance of the balloon when really get into the aneurysm neck, that we can facilitate the treatment process, and we can play with the video though. So we can show that how we can do coiling, packing aneurysm by preserving the side branch, for example, in this case. So we will, as you can see here, we can treat the dome and also cover the aneurysm neck and contour packing to get a good result. And if the patient have recurrence after 6 months, we can always use other devices like flow diverter to completely treat the treatment. So this aneurysm, because of like basilar tip with rupture, with very shallow aneurysm, we can perform double balloon, like for example, like this is a hyperform, to have a good coverage of the aneurysm for even this complex basilar tip aneurysm. Of course, there's a market, there's very type of coil, like Medina, but I think very difficult to get to use in the real patient. This is maybe not progress well. We have many type of the coil, like hyper soft coil, coil with also have biodegradability to improve the aneurysm healing. But however, if we still dealing with a very complex aneurysm, wide neck aneurysm, we need other devices to help for cure the aneurysm. As a remaining problem with when we do coiling, when you keep inflating, there are possibility that we can injure and also rupture of the aneurysm. And also by inflating the balloon, we know that they will reduce the flow and maybe they increase the thromboembolic. However, in the study shows that there's no much difference between the balloon assisted and primary coiling in terms of our outcome of the patient and complication. And also by using balloon, we have reduced the time of the treatment and we can safely perform the packing aneurysm. Again, we can always stage the treatment if we require during the aneurysm cases. So with balloon, we can also have this thing like community device as to protect the neck, continue packing, and because of these designs, just like stent, they don't stop the flow of the blood, so they will maybe have a reduced risk of the thromboembolic. However, in some cases, the coil can be entangled to this device. So we have to do very careful when doing with this procedure. And they have other reconstructive device, like the aim is still to protect the neck and also improve the healing of the aneurysm. So this various method we can treat the aneurysm. So this is how the balloon initially is used to protect the neck, prevent the coil from prolapse, and as you can see here, there is a very good aneurysm that the balloon can really imaginate to the aneurysm neck and also involve in bifurcation, also like terminal aneurysm in basilar tip. So why we need stent? Stent is required for the treat wide neck aneurysm, and also with the stent they can increase the healing and also remodeling of the aneurysm. So however, before we use stent, we must properly prepare the patient with dual antiplatelet. If the patient not prepared well, they can produce, for example, like this, they can develop clot formation after you deploy the stent during the treatment, and you may need to use steroid to overcome this problem. So antiplatelet therapy is very important when we want to use for stent assisted technique and also flow diverter. Even with intrasecular devices, you must prepare and pre-medicate with dual antiplatelet. Most of the time, now we change our dual antiplatelet into ticagrelor aspirin because we know that the Plavix have 25% resistance. The understanding of different type of antiplatelet is very important for us in terms when to do the treatment and the timing of this antiplatelet. For example, if we use ticagrelor, we can load the patient in emergency during the procedure, and we can deploy the stent after 2 hours, and sometimes we can use agristat to cover for few hours in these cases. But I prefer in elective case, I pre-medicate patient 1 day before loading dose, and the next day we continue the standard dose dual antiplatelet aspirin and also ticagrelor BD. And also we have to remember that if we put a patient in dual antiplatelet, we have remind that the neurosurgeon, if they need to do any intervention, maybe like with PSHUNT or tracheostomy for patients with long ventilation after the hemorrhage to stop this medication. At least we know that certain medication, they need longer time to be stopped, and we have to plan this procedure. Especially during acute phase, we try not to use stent because during this treatment, they can have, like I mentioned, have surgical intervention. Patient may have hydrocephalus following the rupture aneurysm, and also they may have vasospasm and GI bleed. When to use stent, we must justify everything to reduce risk, make sure that when we use stent, we don't complicate other things. But sometimes we have no choice. We have to use this stent to treat the patient. We have many types of stent in the market. We have open cell, closed cell, and braided. The most important thing, the configuration of this stent, for example, like open cell, the well opposed to the wall, and you can put the coil through this strut for the treatment. For example, like this is a Neuroform Atlas. You can see how easy to re-enter back to aneurysm compared to other stent like braided and also the closed cell. And the conformability is very important for the aneurysm cure and also remodeling and prevent endoleak. And as mentioned again, I still like to use Neuroform because of the configuration, because I can re-enter the aneurysm start easily compared to other braided and also closed cell. So there's like closed cell, they can have king and they cannot oppose well at the curve, and they can cause complications like thrombosformation at this juncture. So at least we have very good visualization of the stent, and usually this opens spontaneously without any much of shortening this treatment. With the stent, we can have various way on treating of the aneurysm because we can cross the stent through the strut. For example, we can perform, this is one stent, this is standard coiling aneurysm, and this is like Manzil like to do is T stent, H stent, everything stent. And if you have no money, we can also overlap the stent to have our called telescopic and homemade flow diverter. This is when the flow diverter is not available, or if we have problem with the cost, we can deploy this. I think this is enterprise, 3 enterprise to the aneurysm at the basilar trunk. So this is fancy way of doing stenting. Use a braided stent, but we can use now with other intracellular device for this kind of treatment. This is example how we use stent for unruptured ACOM aneurysm. They have 2 aneurysm, one here and another one here. So the initial plan to gel off this catheter and deploy the coil. But when you deal with very small aneurysm like this, if you gel, you can have this kind of problem. See, like this like perforation here. The tip is perforated, and the patient is already on dual antiplatelet. Luckily, nothing happened. We continue packing, even though you can see here that the tip of the SL10 is already protruding into the very shallow aneurysm neck. The procedure is uneventful. So this is how this is, I think, enterprise stent. No, this is Atlas stent to treat this bilobe, not bilobe, the ACOM aneurysm with 2 aneurysm in this segment. Another case is when we need to use stent in acute stage because I think this is more safer option because and the patient also have 2 aneurysm. This unruptured, this is the ruptured one. The aneurysm neck is quite wide and they have very good PCA. So first we treat the ACOM aneurysm followed by treating the large wide neck PCOM aneurysm. The procedure is eventful. However, after we encounter more complex cases that's very difficult for us to decide. This is a very challenging case that I encountered in my life. This is about 13 years old boy with sudden onset of severe headache and also weakness on the right side. As you can see, the MRI is a very large aneurysm. On the CTA, you can see is dissecting aneurysm from the mid basilar up to the basilar top. Angiogram performed, both ICA and also vertebral artery to look how bad this aneurysm. You can see this aneurysm is dissection, but this extend up to the involving the top of the basilar. So this is high flow, impending rupture, is end near the ACA on both sides. And this is very tough to decide how to do this treatment because this is still young patient. Dissection involve the most important segment of the vessel in the body. So whether many options have to discuss with the patient and also the patient relative what kind of the treatment, whether, of course, we try to preserve the vessel, but sometimes they will still have issue putting the flow diverter at this early age and also the antiplatelet regime. And again, in this segment of vessel, there's a lot of perforators that supply the basilar artery and actually have very difficult decision. We discussed in the neuroedic, only Dr. Maimun responded to me how to treat this patient. According to him, he asked me to occlude this origin of this dissection. I did exactly what he did, but I also put some coil inside the sac, maybe to enhance thrombosis, but I also have to take risk, make sure that I hope there's no important perforators or the perforators is fed up from the collateral from outside. This is the most tough decision, even if you want to put flow diverter. Also, maybe next time I will put flow diverter rather than using this technique. This is the aneurysm we use with a periarterial cushion, just using the coil. So it's all right because I think because patient have good collateral from the posterior circulation. But again, the outcome, it worried me when I again talking to my friend that I may kill the patient. Patient condition, however, improving. The only infarcted area is just like the site that before at the dissection component. And we follow up the patient. The aneurysm is smaller, edema become reduced. This is after 3 months. Okay, the aneurysm is no more filling up. They have very good developed the posterior circulation from pattern PCOM to the PCA. And at the 2 years follow-up, this is only chronic infarct here. Then this follow-up patient maybe slight weakness on the right side. I just do 4 years follow-up for this patient to make sure there is no more aneurysm, and I want to see the collateral and also the posterior circulation. And that's good. And this is the remaining infarct. The aneurysm is completely thrombosed. And this is this year. He's taller than me. Aneurysm not growing, and she is growing. So I conclude this my session today is this, the endovascular treatment is evolving, and I believe there is more technology in coil and the stent and also intrasaccular device. If we can develop the stent that doesn't cause thrombosis and doesn't cause any problem like internal hyperplasia, I think it's the best way to treat this aneurysm, because to enter the aneurysm with very fragile wall and the risk of rupture is something that scared of us. If we have this kind of stent with flow modification and also surface modification that can prevent the thromboembolic, I think is the great invention. And thank you very much for inviting me. I think we will have another nice 2 more expensive session with Dr. Uday, with flow diverter, and also next is about contour and also webs. Thank you very much for your attention.
Thank you, Hasbi. There is a small change because Manzil is having a flight preponed, so he's going to speak. So we have preponed his lecture to pre-lunch. So I request Minjil to come down, ready with his presentation. Meanwhile, I request Professor Shyam Kumar and Dr. Swati to join for chairing the session with Dr. Manas and Dr. Narsia. Minjil, please come down. You continue there. He will speak, talk his report. Shyam Kumar sir, may you please? Swati ma'am, please.
Yes, Dr. Uday.
Yeah, Azmi, you can come down. We will take the questions at the end of the session.
Yes, sir.
Shiva, when Minjal is getting
That's a question.
done, yeah.
Yes,
So
sir.
there's no question. There's a comment.
Okay.
That it is it's for your case, the last case which you said that is the biggest challenge in life. See, all of us have occluded hundreds of internal carotid arteries, and we have occluded some basilar arteries too. Now, everyone knows that there is approximately 10% risk of developing an ACOM aneurysm when you occlude internal carotid arteries in 10 years.
Oh, yeah.
Luckily or unluckily, we do not know the data about developing a PCOM aneurysm
I see.
when we occlude the basilar. So that is one area which is still a blind spot. That, of course, you did a fantastic, very effective treatment. But we do not know, going forward 10, 15 years from now, whether there will be a new flow-related aneurysm coming on the PCOM, because there's just no data.
Thank you, Uday. I think we may need to have a longer follow-up for this patient because he's still growing.
That's correct.
Maybe can repeat MRI every 5 years or 3 years, MRI.
Thank you.
Thank you, sir.
Thank you.
Yeah, if there are no other questions, thank you, Dr. Azmi. I'll request Professor Uday Lime to come over and speak on flow diversion in brain aneurysm.
And going by yesterday's experience, I decided that I would rather have the Mac over here rather than not having to play the video, even though there is just one video over here. And thank you for the help. Can you start the presentation? Yeah. Okay, and I still have a minute before I start. So Siba, I congratulate you for one more year of doing this event, which you have done for a long time. And I still have to say that for whatever reason, I'm missing my friend Matthew over here. And I hope that you rectify and we have his presence next year. So, is it okay? Okay. Can you? So I'm going to talk about flow diverters, which easily in aneurysm segment, if I can say that in our lifetime there have been 3 revolutionary concepts. The first one, and our generation is lucky that we have seen them all. The first one is the GDC coils, endovascular treatment of intracranial aneurysms. Wow. The next one is what I'm going to talk about, flow diverters, complex, giant, untreatable aneurysms, excellent results, wow. And the third, Rashmi is going to talk about, that's about the web device and intrasaccular devices. You know, in aneurysm treatment, these 3 things have really taken giant leaps to take the treatment forward by eons. Now, I'm going to, of course, I have to do this talk, so I will have the usual stuff. And then when it comes to the cases, I'm just going to show it as a pictorial assay, because most of us who are present in the hall may be already doing it, and there's nothing really new for them. And so maybe it will be directed specifically to Manas. Please don't mind. So flow diverters. You know, flow diverters is, those of you who are not neurointerventionists, when we hear the term diverter, this is what we have heard it before. The canal diverting it to the farm, and of course the road closures and diversions, which is a pain. I come from Bombay, big pain. And the third one is in our bathrooms. We can divert it from the shower to the tap. And flow diverter is something similar, but the difference is that we are not diverting the flow from a main channel to another channel. We are diverting the flow from an intracranial aneurysm towards the artery, the main artery. And this is the reason why flow diverters were developed. These were completely untreatable aneurysms. Surgery, coils, whatever. They were untreatable before, unless you sacrifice the artery, which is not possible every time if the cross flow is not good enough. We have done it, as just continuing the discussion I had with Carol, we have done it for many years, giant aneurysms like this, fantastic cross flow, occlude the artery, extremely effective treatment with the 10% over 10 years risk of developing a new aneurysm, ACOM aneurysm, which some of our patients have. But so this is deconstructive therapy. It's always more attractive to have reconstructive therapy. And that's why the flow diverters were developed. And these are several indications wherein we use the flow diverters. I'll give you why I said that our generation is so lucky is because when we were still starting the business of so-called interventional radiology, not neurointervention, we had a meeting in the mid-90s with our American Indian Barry Mehta. And that was the time that, we starry-eyed, we were sitting on his table talking about various things. He was talking and we were listening. And that was the first time we heard this term, the bridging device for aneurysms. And that was mid-90s. And less than 15 years, we are actually doing it. And now, the next 15 years, it's commonplace. Everyone is doing it. Hundreds, thousands of aneurysms each year have been treated by flow diverters. So this is where the technology is going. And we are very lucky that, we have seen it all. This is the result of the case which I showed in the first slide. If something can do it, something can restore the artery, something can give you a new, pristine artery, then, that technique is going to be here to stay. This is Saru's case. When India did not have flow diverters, and we used to go to all conferences and looking at fantastic flow diversion cases, we saw this case, the Saruhan Sakrije. And look at this. It's a terrible aneurysm, and if a stent can do those convolutions which you see in the middle slide and repair the artery, which you see in the other two pictures, this is wow. And this was like nearly 20 years ago. And he could manage that. And I have this picture, and I keep this picture because there are few things which have taken our specialty ahead, and this is one of those. So FDs, everyone knows that FD is actually a stent for people who do not know neurointervention. It's a stent. It's a specialized stent with extremely tight struts so that the blood does not go into the aneurysm. The blood flow decreases, the aneurysm thromboses, and then it shrinks. Many times it's not as simple as that. It is, of course, has to be microcatheter deliverable, and once you have a device, you're always going to have additions and improvements of the device, which have happened over the last 15 years or so. This was launched, as I said, in 2008 worldwide. In India, it came to 2012. See, it's already more than 10 years, where we still remember we went to the launch and the first cases were done, and now it's just commonplace. So how do we make it better? We make it better by having smaller microcatheters. Of course, to deploy it, to take it, should be easier. And once we deploy, it should deploy easily, and then we should have efficacy and long-term duration where it is efficacious, at the same time, it's safe. It happens, but it happens like 80 to 90% of times. So it is still not perfected that it is nearly 100%, no. So durability of result is excellent with flow diverters. The effectiveness is very high. 80% of aneurysms have full occlusion on follow-up, and overall complications or technical difficulties are less than 10%. And I am, of course, talking about aneurysms which are complex aneurysms, difficult to treat, hitherto untreatable aneurysms before the FDs came. There are 5 flow diverters available in India. P64 has been taken off the market. I'm sure that next year they will come. And so PIPE is the first pipeline. Vantage is the first. Vantage is a recent addition. That's the fourth improvement on the original pipeline. It's still here, going strong. Vista Babies I'm showing, but Vista Mama and Silk, the original Silk, was the second flow diverter in the market. This is by Bolt. It's still here. And of course, there is the Striker Surpass, which is the third generation of it. It's called Surpass Evolve. It's going strong in India. And there is Fred by Microvention. Now it is FredX. It is there, significant. So, these are some of the flow diverters that we have. The last entrant has been from Acandis, the German company, and they have a flow diverter which is very similar in behavior to the Surpass and the pipeline. It's called the Derivo. And the newer improvisations have been, of course, the braid. Braid used to be 96, then 74, 72, 64, and now it is 48 is a standardized braid. Many times it comes with the technology with surface coating. Why? Because the problem always is going to be antiplatelet medication, many times lifelong. And so we have the surface coating in the newer flow diverters. 2 types, either they are cobalt chromium or they are nitinol. And the behavior differs, and we should have experience to know that which will work best in which anatomy and in your hands. This is the most important thing. I already said that 80% occlusion rates of difficult aneurysms, less than 10% complications and technicalities. The antiplatelet medication is still an issue where everyone is working on it, and then we will have some surface coating so that we can reduce or stop antiplatelet medications in 6 months or a year. Now, from here on, it is just going to be pictures, so I don't have to talk much. You can look at it. The pictures speak better than words. And of course, you can look at it faster than I can talk. Giant posterior wall, supraclinoid ICA, no neck or very wide neck, left hemisphere, important arteries coming from it. And these are the results which is commonplace. All the slides that I'm going to show from now over the next 5 to 7 minutes are going to show you very pretty pictures. This is the second case. Looks like normal. Is it normal? It is not. It's normal now because when it came, it was like this. It's a full calcific aneurysm, very difficult to clip because the clip will slip on the aneurysm on the wall. Giant aneurysm, of course, treated with a single flow diverter, good follow-up. Another tough case, one of our initial cases, where there is a large aneurysm, and you can see that there is a thrombus inside the aneurysm, and distal artery has those bumps. So the whole artery is abnormal. We covered the whole artery coming from top to bottom, long pipeline, 425, worked very well, and you can see that the artery is healed, and there is that white line. You know, all those terminologies people have forgotten now, but we used to see it and use those terminologies back 10 years ago. The white line between the flow diverter and the arterial wall, and of course, that's how we know that the artery is healed completely. Similar, cavernous giant, a few coils, good result on follow-up. Again, few coils, very good result on follow-up. Pictorial assay, so there's nothing much to talk about. It's fantastic pictures. These are the toughest aneurysms that you will treat, a giant aneurysm on top of the artery. And regardless of what you do, they are, even today, the toughest aneurysms that you'll treat. This did very well with one flow diverter going from MCA to the supracrinoid, and with a lot of coils in. We didn't have to occlude the A1 on the other side. You can see that antegrade flow is maintained on the ICA top, and we have 9 years follow-up on this guy. Similar tough case, and a flow diverter with coils, with the result which speaks for itself. Smaller one, you can call it easier one. There's nothing easy in our branch. Now I will change the subject a little bit about dissecting aneurysms, which very often come with a bleed. So when they come with a bleed, the issue of antiplatelet is always to be considered. So now we have these newer surface-coated flow diverters, which we are using. The companies, they don't say that it is okay to be used with one antiplatelet, but we have still used it. They say that you can use with one antiplatelet, which has to be either prasugrel or Brilinta, but we have used some of these bad bleed patients only with ecosprin. And believe me, small numbers, maybe 10, but none of them have thrombosed or rebled. So there's something in the data, but it is not commonplace yet. Head injury, dissecting aneurysm, bad bleed, young patient, bad spasm. So we had to treat her with flow diverter, coils, retreat her for spasm. Eventual outcome, very, very good. Full reconstruction of a badly traumatized artery with dissection. Single antiplatelet again. The next 3-4 cases are bled cases with single antiplatelet, bad-looking aneurysms, flow diverters. Look at this. We are scared about giving, because these patients might require a procedure, either a craniotomy or a shunt or even an EVD. And so if you can avoid or minimize the antiplatelet, it always is a good idea. All these patients have done well. As I said, none of them have rethrombosed.
Mostly brain AVMs in our practice located in hemisphere, and 9% was in the cerebellum, and nearly 2% in brainstem. With the special matter grading, the most of the AVMs was grade 3 and grade 4. We treat also the grade 5 brain AVM. And complete obliteration after embolization is 53%, stable occlusion 49%, and partial embolization in 51%. And 13 patients were sent for the surgical removal. In some cases, it was after intraprocedural or after operational rupture, stage endovascular treatment in 186 cases, and gamma knife surgery in 5 patients. We like to combine liquid embolics, and nowadays single liquid embolics in half of the cases, and most part we try to mix 2 or 3 liquid embolic, and we also use coil for the pressure cooking. And combination with fill shows very nice results and good penetration. And also we have complications, and in unruptured patients, non-disabling hemorrhage and ischemia. It's nearly 60%, and 40% is disabling, and it's still high percentage. And total nearly 14% of complication, and non-disabling it's more than half. Nearly 6% still disabling complication in brain AVM treatment. And in overall our treatment, comparing with brain aneurysm treatment, intracranial stenosis, tumor embolization, the brain and AVM complications is still high. And there is a lot of explanation why this complication happened, and we work on decreasing all this amount of complications. Our practice were changed in 2012. I visited Essen, and I have seen how the pressure cooker technique is done, and it was really changed in our practice. Before 2012, we used marathon catheter, and most of our complications were brain arteries dissection and the rupture because of marathon and because of the retrieval technique of this catheter. And in 2012, Apollo catheter came to Kazakhstan, and in 2014, we reached the sonic catheters. And pressure cooker, usually it's a one detachable catheter, and René is doing with the second, usually Magic, and he's injecting liquid coils, Berenstein coils, and then he put NBCA, usually 50%, and doing super selective angio after the coils, and it's very fast and quick, effective injection of liquid embolic. And nowadays he's using mostly Squid 12, but in our practice we had no liquid coils, and we just modified the technique. We used 2 detachable catheters, start to inject liquid embolic, and then after short reflux, we injected 60 to 70% of NBCA and detached the second microcatheter, usually with detachable tip, and it's very useful for the long
NBCA injection, and it was very effective. The first case, the boy, 11 years old, the first time my colleagues treated through the Hübner artery, and it was just the afferent embolization, and the rest of the AVM was left in basal ganglia. And if you notice, there is a deep venous occlusion. The straight sinus is occluded, and main branch was a lenticulostrating artery. And it was my first time using the modification of the pressure cooker technique. I took 1.5 centimeter two Apollos with the balloon assistance, and then start to inject Onyx 18. It was in 2013. And then small drop of glue with the second Apollo, with the complete obliteration of the brain AVM. It was nice, but 11 years old, I used 8 French guiding catheter, 3 devices, and yes, it was tachycardia. I had tachycardia during the case because of small vessel, lenticulostrator, and navigation of 2 Apollos. It's all the time a little bit scary. And patient discharged without additional neurologic deficit. And the second case we have done during the NERADICT forum in Almaty in 2013, and the same technique, the first Onyx 34, then squeeze and fill, and 50 to 70% of NBCA with the sonic, and the second catheter detached, and with the complete obliteration of the brain AVM with no additional deficit. The other patient with the ruptured MC aneurysm, the first we balloon assist coiled the aneurysm, and then in a couple of weeks we took this patient for the pressure cooker technique. We start with the 2 Apollos, injected liquid embolics, and then NBCA with the complete obliteration of the brain AVM with no additional neurologic deficit. And this is post-op. And unfortunately, Trufel went from the market in 2019, and we stopped to use NBCA because it's very cheap, and for the distributor company, it's not interesting to sell cheap material, and we switch for the fill first technique. And it's very effective technique, and we can use only 1 microcatheter. We start with the, this is first session, partial brain AVM embolization, and during the second session, we took 3 microcatheters, 2 for superselective angiography and 1 for fill first, and continuing with the Onyx. And AVM was completely occluded in 45 minutes. And it's very effective, and fill creates very stable reflux, and it's comparing with the pressure cooker technique. I think it's comparable, and it's very stable and reliable. And the other case, we occluded this AVM in 2 sessions with the fill first combination with the squid, with a complete exclusion from the circulation the brain AVM in very young lady. It was under-ruptured, but patient had a headache. And in our country, if a gynecologist knows that patient has a brain AVM, this young lady never will give birth for the children. That's why it's an indication in additional indication in unruptured cases. This is ruptured case. 2 microcatheters sonic with a fill in combination with squid. In total, 12-minute injection with a stable reflux, and it's very controllable. This is drawing. Controlled ESA. And the other technique is coil assist embolization. Patient has a frontoparietal region, paracentral brain AVM ruptured. We just coiled the distal part of the branch, pericallosal artery and the proximal, and also additional coil placed in callosum marginal and additional coil placed in pericallosal artery without detaching. It was worked like a balloon, and we controlled this branch during the injection of squid. And after embolization, we took out the third coil. It wasn't necessary to leave it there, and we keep the patency of the pericallosal artery. Sometimes it works, and it's nice technique, and it's also helpful for the colleagues who scary to use balloon assistance, because in small artery using balloon sometimes might cause the artery dissection or rupture. That's why common HE-like device or coils very helpful in such anatomical places. Emergency embolization, both ventricles drainages, and we start with fill first, and in 40 minutes we injected squid and onyx 18 and 20, and completely excluded AVM from the circulation. Patient was in comatose status, and he's MRS3 nowadays. And other child combination of Onyx 34 2018, one session. It's ruptured case, 7 years old. The treatment done on monoplane machine in Tashkent in Uzbekistan without additional neurological deficit. And the advantage of the fill first, short reflux, no coils, no NBCA, 1 microcatheter, simple when a single operator, and most of the cases 1 syringe of fill in combination of other liquid material like onyx, squid, or menox. Transvenous and transarterial combination, ruptured AVM of the basal ganglia with the stenosis on the draining vein. We placed sonic transvenously, the other sonic in lenticulostrating artery with the balloon assistance, with the complete obliteration of the brain AVM. Combined treatment, we did partial embolization of this AVM, and AVM ruptured, and patient came with headache, and we did additional embolization and sent patient for the microsurgery with the complete exclusion of the AVM. In such a large, nearly 6 centimeter brain AVM, the microsurgery is a nice additional option. And I think this part is very interesting. Patient with the basal ganglia AVM, nearly less than 3 centimeter, with the aneurysms on afferents from lenticulostrating artery. We have done transarterial embolization with complete exclusion, but patient was 73 years old, hypertensive, and on day 5, patient had a massive bleeding, and there is two possible options. One is venous thrombosis with a rupture. It could be venous infarction. And the second option, a patient just had a hypertensive hemorrhage. And post-mortem, we couldn't say which one is correct because after treatment, venous draining vein is also thrombosing, and the patient could have 200 millimeter systolic, and it also might cause bleeding. And this patient expired at the day he was craniectomied, and on day 5 we lost him. And 32 years old patient with a thalamic and basal ganglia AVM. I think I already showed on a monsoon meeting this case, and we decided to go from the anterior thalamo-perforating artery. We injected NBCA, and it was partial embolization.
we would like Dr. K. Narsingh Rao to present a memento to Dr. Minzil. Next, we would like Dr. Narsingh Rao sir to remain on the stage. Dr. Uday sir will present a memento to Dr. Narsingh Rao. Thank you once again to all the speakers and chairpersons. We will now be taking a short lunch break. Thanks to all the speakers for keeping us on track. We will again reconvene at 2.
of this aneurysm. This is the braided stent across the neck of the aneurysm, and this is how it looked like. The aneurysm is excluded with a stent across, and this is the follow-up angiogram after 1 year, where you can see that the aneurysm is completely excluded with a stable exclusion at 1 year, end of 1 year. This is the next case where the patient is having a sudden severe headache with minimal subarachnoid hemorrhage, a CT scan. Again, this is technically challenging because you can see that the aneurysm is very, very flat, super flat aneurysm, and there's a very, very wide neck. And once you take a catheter, the catheter is not going to stay stable over here. And once you put a stent, you cannot go through the stent here easily because the wire and the stent might just, the wire and microcatheter might just perforate this flat, shallow ACOM aneurysm. So this was the plan. We did that. This is the aneurysm. So we will do a balloon assisted coiling, and then we will put a stent, but that didn't work. So what we did is we first deployed a stent, then took a microcatheter to coil, and then we put a balloon across here to give a support. So this is a stent, this is a balloon across the stent, and the third catheter which is just going for the coiling. This is how we executed, very, very flat. It's very difficult to keep any kind of coils over there. So first we did a balloon assisted coiling. You can see the microcatheter for coiling is over here, and then put a balloon, but still there is hardly any space for us to keep the coil. The coil will keep flying into the ipsilateral A2. So we went on to the plan B, and in that first we deployed a stent here. To the stent we went ahead the balloon, and then the other microcatheter started coiling the aneurysm. We can see the stent over here, there's the balloon, and this is the coil, and finally we could exclude this aneurysm completely with a safe outcome. And the other thing that has come up is a flow diverter, intrasaccular and extrasaccular, that has made life even further easier. Okay.
Thank you so much, Talai sir.
Yeah,
for your
1 minute.
1 minute.
Yeah, no, it's good you showed some of your recurrence in your experience. And what are the cases had recurrence? Could you predict?
Yeah.
Yeah.
Most of the cases where we expect recurrence is large or giant PCOM aneurysms, or any aneurysm which is more than 15 millimeter. We can expect a recurrence, and we continue to do a follow-up at least for 5 years. So previously, those cases which used to come to us, which is 10 millimeter or more in the PCOM, we used to do many types of treatment like balloon assisted coiling, stent assisted coiling and all. Nowadays, straight away we are advising we have to do a flow diverter with or without coils. That has reduced the recurrence.
So means what is your recurrence rate like 5 years ago and present like 10?
With a
10
flow
years?
diverter, the recurrence rate is less than 5% in a large or giant aneurysm on the ICA. And without that, it could be around 30 to 40%. For a large or giant aneurysm on the PCOM 5 years back, without flow diverter, recurrence rate was about 40%.
Thank you.
Good evening.
Shivu, nice presentation. Just to add the last discussion about the meningiomas embolization. Meningiomas of my life in neurosurgery. But what I want to say is that embolization curing meningioma is absolutely is not at all an issue. It is never described. I think if it is done, it should be a case report.
So meningioma, basically, whenever it is diagnosed, we try to understand from MRI that whether it is a very highly vascular meningioma. If in that is the case, then we try to do pre-operative embolization. Embolization per se as a curative procedure for meningioma is not so well taken. I have not heard or seen much evidence.
I just want to highlight because there are certain statements which
but
are made.
embolization for meningioma, we have done
to make
embolization for meningioma.
Yeah.
Yes.
Thank you.
I have seen couple of his follow-up cases where they remain stable or little, they have reduced little size, but completely disappearing I have not seen because we are in a common WhatsApp group. Because he himself is a neurosurgeon and running the neurosurgery department and endovascular department, they are doing some embolization and following it up because the symptoms have come down. But saying that meningioma can be cured by embolization in 2023 looks little far-fetched.
Little too much. Thank you.
Good evening. Yeah. Now we are at the end of the session. I see that the crowd is also becoming thinner. I thank all the doctors who are staying till the end of the session to be with us. I'm a neurophysician. I'm Dr. Sumedha. So as I was going through the list of the topics, when I came through this particular title, Management of Technically Challenging Aneurysms, I can think of no other person to deliver this talk other than Dr. Shiva Dalai sir. Thank you, sir, for inviting me to be the moderator here. Each and every case that you have shown here is very technically challenging, and the excellent work that you have done, I'm sure that you must also have got adequate clinical improvement in the patient. As a neurophysician, my role comes after the procedure, whether it is a neurosurgery and microscopic surgery of the aneurysm or the endovascular therapy. After the surgery, when taking care of the patient, monitoring and seeing that the patient doesn't have delayed complications is where I come into. So now, as sir has already shown that there are n number of patients where you cannot go by textbook guidelines. There are a lot of things that you have to decide on table while you're operating either on cath lab or in the operation theater. And we have to take on-table decisions, and I sincerely appreciate the efforts of my colleague neurosurgeons and intervention radiologists to do a technically great job in saving the patient's life. Thank you. I think if any other questions are there, we'll entertain. Otherwise, we'll go to the next talk.
Sir, just 1 minute. I'm Dr. Ramnaidu, critical care physician. We are more interested to know the complications depending on the location. This is a question for both neurosurgeons as well as interventional radiologists. Depending on the location, which one is a difficult location for an operator of neurointerventional radiologist when compared to neurosurgeon, and vice versa, neurosurgery, where the difficult location that can be easy to the neurointerventional radiologist. Is it anything entity like this? And other thing is, depending on the location, can we predict the complications, which are the more expected complications, depending on the surgical difficulty or interventional difficulty?
That's a good question. So whenever we say that in comparison, that means either we are comparing with a modality, or we are comparing with a location, or we are comparing operators. So here I would say that you asked about the location. MCA bifurcations are much easier treated by surgery than endovascular method. Although we have like contour and the web devices, still I would prefer that MCA bifurcation can be clipped. And the posterior circulation aneurysms are difficult surgically compared to endovascularly, like a basilar top, mid basilar, or a dissecting vertebral artery aneurysm, intracranial vertebral, or a pike aneurysm. So they are difficult surgically, they are much easier endovascularly. So that is what. And there are some type of ACOM aneurysm where both the ACOMs are incorporated. They could be equally challenging for both.
Okay, any differing idea from neurosurgeons, sir? From your perspective, just want to know.
If I'm audible, Dr. Shiv Shankar Dalai might not like the competing statements that I might make in next 2 or 3 sentences. But in this session right now, amongst the few people left behind, we have one of the best surgeons that the country has ever produced. Dr. Manas and his 2 students, Dr. Narsingh and me, are sitting right here. And if the question, the way I have understood, is by location, what makes it simpler for endovascular versus surgery, right?
Yes, sir.
So if the question is that over a period of years, means when skull-based surgeries and cerebrovascular surgeries actually started taking its shape and started giving their outcomes way back in 2000, 2001, once Professor Manas returned from United States after doing his fellowship. That time was revolutionary actually. What were previously looking like inoperable ones and the ones that did not have good outcomes like basilar top aneurysms, like posterior fossa vertebral artery aneurysms, these were unthinkable in 1990s. But once the advancements in the surgical approaches came, and once Dr. Manas started demonstrating it in Nizams, and we were his direct residents, we started believing that yes, these could be approached. And over a period of 20-25 years now, people have evolved, we have evolved, the techniques have evolved, and now for the people who know it, who have done it routinely, for them it is fine, just another day. A far lateral approach for a vertebral artery aneurysm, or a subtemporal or an transsylvian approach, frontotemporal orbitozygomatic approaches for basilar top aneurysms, or a complex bypass that can be added to a larger size aneurysm. These are all routine for select few who have done it over a period of years. Okay, so taking endovascular into account, people have that experience to handle the complications that the procedure has. If they can deal with it, endovascular or surgery, both of them can go ahead with equal ease for every aneurysm or AVM there. You have the experience to handle the complications, you should go ahead with it, depending upon what you are good at. So for surgeon, it is surgery. For endovascular interventionist, it is coiling, flow diverter, whatever. Right, Dalai?
I liked it, but you started saying that I'll not like what you will say. I loved it.
I do not know, you don't like the competitiveness with which surgeons speak.
We will deal with both your cases.
See, what else Suresh sir could have said? He clearly said that whoever can handle it better, let him handle, no problem. That's all. Finish. Thank you. Thanks. So let's go ahead to the next one.
Thank you so much, sir. We'll move on to the next topic, that is going to be covered by Dr. K.C. Patro, sir. It's about radiosurgery, what can be achieved in brain AVM management. Welcome, sir.
So one of my friend asked, what is the indication of radiosurgery in AVM? So I told, when there is no option, you follow radiation. So when neurosurgeon intervention radiology, they sent to us, then we start radiation. Because most of the cases, my presentation, I think, oh, yeah. No? One here? Yeah. It's on, no? So after all talks, I no need to talk about what is AVM. and the tortuous vessels, the feeder, the drainer, I don't want to talk, but location, it can happen anywhere. And so why clinical is so important? Bleeding in the brain, reduced oxygen to the brain tissue, aneurysm formation, brain damage, and stroke-like peaks due to hemorrhage. So treatment options, as you know, Aruba trial also, there is one arm is the observation also. So observation, surgery, embolization, and SRS. So after the embolization, if there are residual AVM, we can go for the SRS. So if you see the treatment algorithm from the small volume lobar location to small volume deep location, large volume lobar location, and large volume deep location, in all the algorithm, radiosurgery one of the options. And if there is a small volume deep location, radiosurgery is the first option. And as you know, grading of AVM Schlechter-Martin score, the lesser the score and better the outcome. And if you go for the grading system and find out what is the algorithm, and if you see again in all the under arrows, the box is showing there is a role of SRS. So why SRS? Why we should go for SRS? There is a non-invasive, no incision, obliteration rates are comparable, eloquent areas, deep location, residual after embolization, and among the minimally invasive therapy for non-surgical AVMs, and it is good for the smaller than 2.5 centimeter and diameter less than 10 cc. So eloquent areas AVM surgery, where the surgery is a big problem, sensory motor cortex, language cortex, visual cortex, internal capsule, thalamus, hypothalamus, cerebellar peduncle, deep cerebellar nuclei, and the brainstem. So if you see the radiology, as you know, DSA is the gold standard, and because every hospitals and the radiation departments not equipped with DSA, so we do with MR and CT angio. So as a radiologist, when somebody has reported, and as a radiation oncologist myself, when I have to see 16 characteristics where the number of AVM, location, size, feeding artery, draining vein, clot, nidus, edema. So you have to see the 16 characteristics for the radiological option. So what is the mechanism of obliteration? So main mechanism of obliteration is the inflammation, endothelial endothelial deproliferation, and there is a lots of cytokine mediated blockage and fibroblast formation. So this is the tissue specific cytokines, inflammatory process, and myofibroblasts together that form a fibrosis and obliteration in the long run. It is not an acute effect. So dose of SRS, as there is a index called K index, how much dose of radiation we can give. The most of the depends upon the minimum dose by volume, cube root of volume. So suppose K index usually kept at 7, and the dose usually required, if the volume of the nidus volume is 5.8 cc by 27 by cube root of 5 is usually 15 gram. So usually we go for the single fraction SRS for the single dose radiation. We usually go for less than 2 centimeter, we go for the 20 gray. 2 to 3 centimeter, we go for 18 gray. And more than 3 centimeter, we go for the 15 gray. Apart from that, when there is a big lesion and the thalamic location, brainstem location, we usually avoid single fraction radiosurgery. We go for the multi-fraction radiosurgery. So if you do obliteration and AVM dose response relationship after 20 gray, there is a plateau curve. There is no much difference in the obliteration area. So is embolization needed before radiosurgery AVM? So it is nidus obliteration was achieved with 47 of the embolization group and 70% in the radiosurgery group. So embolization, if needed, you can do, but after embolization, we should not jump directly to go for the radiosurgery as soon as possible, because the nidus volume will be misleading you and for the radiotherapy. So post-bleed and post-embolization, you have to wait for the 3 months, 1 to 3 months to clots come down, then we go for the stereotactic radiosurgery. To obliterate rate of AVM SRS is not directly proportional. It depends on the many factors like the location, volume, the age, all factors, if you these are many radiosurgery, Virginia score, and many scores are there and many scales are there. So they together to form the lesser the score, better the outcome. So there is another score is called RBSA score, radiosurgery based AVM score. So this is a case of AVM on the parietal bone, right parietal lobe. And after the 16 months, you can see on the right side of there is a no lesion, slightly T2 changes are there. Same thing, if you see posterior parietal frontal lesion, there is a lesion here. After 16 months, there is a slight change in the area, but not much T2 changes. Again, case 3, it is an insular lobe where the surgery is a big problem. So we can plan for the radiosurgery, and you can see there is hardly any T2 changes. Another is intraventricular AVM, where we can giving a 16 gray single dose, single fraction radiation, and you can see the obliteration. Another thing is the stereotactic radiosurgery for dural carotid sinus fistulas. We can, this is the sinus fistula, you can see the pre-SRS DSA, and you can see the single fraction around 15 gray radiation dose to that carotid fistula. After the post-DSA, there is a obliteration of the fistula. And this is the intracranial cavernous malformations. If you see, this is the various scores. We can these things. Very small cavernous malformations. We can go for the single dose around 12 to 14 gray. Single radiation dose is sufficient. Same thing is a corpus callosal cavernous malformation. And with a single dose of 12 gray, we can you can see the patient is symptomatically improved and there is no lesion now. Posterior ventricular cavernous malformation, you can see after the 2 to 3 years pictures are there is obliteration of the cavernous malformation. Another is a posterior frontal lobe cavernous malformation, and after single fraction radiosurgery, the lesion size is decreased and patient is better. It is a AVM of frontal lobe, and there is a single fraction radiation, and this is also is a obliteration. So if some volume is more than 15 cc or 20 cc, we cannot go for the single fraction radiation. So we can see this is called volume staged radiation. We treat half of the volume, only the nidus volume, not the feeder, not the drainer. Only the nidus volume, you give the radiation to that area in one session. After 3 to 4 years, another session, we have to give radiation. So this is the procedure what we follow. Actually, so this is the first, So this is the first nidus, and after first radiation, there is after 3 to 4 years, there is a small volume. Again, we can repeat SRS. So analyzing the aneurysms in the AVM before SRS, it is important if there is a intranidus and perinidal aneurysms. So that is important if there is a chance of bleed is high. So mostly it is seen that intranidal aneurysm does not cause much problem, but perinidal proximal aneurysms is a causing problem. Sometimes the many people they think that there is a brain necrosis, and we there is a this is called Fleckinger curve, and we calculate the pi score, how the necrosis will happen. So this is the we see with brain minus PTV, brain minus the nidus, we keep the volume 12 gray less than 10 cc. So this is, we follow this. If you increase the dose, there is a necrosis chances are high. So maximum dose is 20 gray, we give radiation, and peripheral dose we should keep below 10 gray. And 6 monthly, we just do not the DSA, we do the MRA, and DSA is again some small invasive procedure, patient needs admission, and we follow the response evaluation with the DSA. So what is the stereotactic radiotherapy? Stereotactic radiotherapy is nothing. It is a type of radiation therapy which is used for the cancer treatment and precisely target, and we give high single dose radiation. And mostly this is the high dose, exact localization and by the various immobilization. So there is no knife involved at all. So this is, so we can give single fraction SRS by whether less than 3 centimeter, fractionated SRS when there is a larger volume, fraction we give 3 to 5 fractions. And so what are the advantages? What are the advantages of the SRS over the other procedures? Because there is a decreased length of stay, decreased cost, rapid return up to the full employment, and a single day treatment around 10 to 20 minutes treatment, and that is sufficient for the obliteration. So this is the person who invents the frame, and he is the legend Raymond Kegelberg. So this SRS started in 1959. You can see this in 1959. He is the legend who treated with many SRS AVMs with SRS. Another person who given the necrosis curves and all things, he is the Flickinger. And so previously the procedure, SRS procedures are very invasive procedures where the people do for the gamma knife radiosurgery, they do the implant, fixed frames, and the patient has to suffer and run behind the department to department. Now we are doing without any fixed frames, we are doing with this non-invasive procedures. So people have mostly they think, mostly they feel that that is a gamma knife. Do we have a gamma knife for the do these things? So previously gamma knife, when the radiosurgery started on the based on the gamma knife. Now we have a X knife. So gamma knife is the radioactive substance, cobalt, through cobalt they do. Now we do with the linear accelerator where we can do with a cyber knife, we can do with a Electa, Varian, what we have a normal linear accelerators we can do. So this is the gamma knife. As you know, there are a number of cobalt sources used. Now this is the radiation machine what we have. So any radiation departments have, this is the radiosurgery department. We can do very simple procedure, online CT scan, inbuilt CT scans. We can do the radiosurgery in these things. So what is the comparing to the X knife, compared to the gamma knife, what is the advantage of X knife? Again, it is it is no invasive procedure, no fixed frame is required, and mostly non-invasive, equally effective and cheaper. And availability is everywhere. So there are various requirements like cones, fixation mask, onboard CT, everything is required. So these are the many requirements. So this is the micro MLC. So according to the shape of the nidus or shape of the tumor, this micro MLC is required to treat the patient. So these are the small cones. If there is a small lobular rounded structure, you can go with this cones in your hospital. And anything is required is the CT, MRI, and DSA. So now we are replacing the DSA. DSA is the gold standard. If you don't have any DSA, because all radiation departments have not the DSA, so we are taking the help of MR angio and CT angio. So this is the planning system where we can do the SRS planning, and these are the verification system. We can see this is the 2 CTs. We taken the 1 CT during the diagnosis and treatment. We can fuse together, and you can see exactly the localization happens or exact treatment happens or not with a sub-millimeter accuracy. And for the sub-millimeter accuracy, we want this radiation department, mostly those who are doing radiation SRS, this is called a hexapod couch. Sub-millimeter accuracy can be corrected by this linear accelerator. So again, lots of quality assurances are there with that machine. We have to do, but there is a mostly non-invasive. So any lesion less than 3 centimeter can be taken by single fraction and mostly by mostly in the eloquenters. The basic mechanism SRS is the high dose, strict immobilization, 10 to 20 minutes of treatment. So radiobiology, what is the radiobiology? Mostly behind the SRS is the massive vascular damage and fibroblast formation. It is the mostly by cytokines, that is the main one. So what guidelines, is there any guidelines to do the SRS for the AVMs? Yes, these are the ISNR guideline. Then there is American Physicists of Medicine, that is one guideline, and the IRSA guideline. There are many guidelines are there. though, for the AVM. Here I am going to tell you one patient with 23-year-old female, ECOG 1, sudden onset headache, weakness of left upper limb, lower limb, evaluated outside, images are not available when he came to me. So right parasagittal, parapulsine, T2 hyperintense lesion, flare and no restriction and no suggestive of infarct. So location is right high posterior parietal vascular malformation. It is around 3.4 centimeter. We don't want the total AVM to be treated. Only nidus has to be targeted. So this is the nidus size is 1.6 centimeter. Arterial supply from the pericolloidal and collagomeningeal branches of the right anterior cerebral artery. Venous are cortical veins. Hemoglobin degradation products when we taken the MRI. So this is the lesion here. You can see this is the lesion and this is the nidus MR angio after 3 months. As I told, when the patient presented with hemorrhage or ruptured, not to treat all and sudden further treatment. We have to wait 3 months to prevent the bias from the degradation products of hemoglobin degradation products. So this is the thing after 3 months, these things. Then so it diagnosed AVM right parietal lobe. And with the help of, it is a case of Dr. Suresh sir. He is so neurosurgeon, intervention radiologist and radiation oncologist together has to work. It is not a job of a single person. It is a multidisciplinary approach. So tumor board decision we have taken in our hospital to better go for the SRS and stereotactic radiosurgery planned. We have discussed about the procedure, with the patient, about the imaging, about the obliteration rate, about the complications, and because he is a young married girl, so she was apprehensive about the pregnancy after the SRS. So we discussed about the evidence of pregnancy after within 3 years. So we discussed about the obliteration rate, rebleed, symptomatic radionecrosis, and procedures we have explained. So pregnancy should be avoided after the SRS for the 3 years. So complications mostly another malignancy, bleed, convulsion, deficit and raised acidity, though they are rare, and there is a high chance of cyst formation also. So we have given 18 gray single fraction with 10 minutes of radiation. And this is the procedure where we used no mask, no invasive mask, only simple mask used. And we did the MRI protocol, we taken the MR angio and with a planning CT, and we just taken the help of a neurosurgeon as well as the radiologist to find out the nidus. So nidus is around 5.8 cc, and after multiplanar evaluation, this is the nidus on the CT what we contoured with the help of neurosurgeon as well as the radiologist. So this after the MRI and CT fusion, we just planned the small area, and the nidus multiplanar evaluation we did, and this is the proper volume. It is 9 cc after giving the PTV. So this is the nidus, and this is the things, and vital structures what we do is optic chiasm, optic apparatus, and brainstem, and we done with the plannings, and we do given at the around 15 gray, 18 gray, and these are the beam arrangements and what is the thing, what plan for the SRS. And these are the parameters, how to get the proper dosage schedule to the, mostly the radiation oncology related, and this is the how the radiation doses to the AVM area. And these are the radiation doses to the optic apparatus like eye, optic nerve, optic chiasm, brainstem, and cochlea. And do rigorous quality assurance test, and patient treated. So we did treated this patient in 2020. Now patient is followed for 3 years, and after the treatment, we give the pre-medication of the dexamethasone to prevent edema, ondansetron for the vomiting, and anti-epileptics for the 6 to 8 weeks, and tipper the steroid for 3 years. Now patient is doing well, 2-year follow-up, but with our against of our advice, she is pregnant, and I think they are not for the follow-up. So this is the procedure what we do for the SRS techniques in the radiosurgery technique for the AVMs. So it is a multidisciplinary decision, deep location, eloquent location, post-embolization residual, non-invasive, single-day procedure of 20 minutes, and established technique. So these are the things where we treat the for the radiation procedure. Thank you, Dr. Dalai sir, bhai, and Arvind bhai, so for the calling. Thank you very much.
Sir, can I ask you a question?
Questions. Hello?
Sir, sir, from here, sir.
Yeah.
Sir, very eloquent and actually very good presentation. And only one, sir, doubt I had that you have advised that for a lady not to get into pregnancy for 2 years, but it is standard protocol is 6 months. This is for the fear of recurrence or relapse, or sir, 2 years not to get pregnancy. That is, sir, 6 months is the protocol, but this 2 years for recurrence or relapse.
Dr. Kanu, please come on to the mic.
Yeah. So actually, there various studies are there. After SRS, if the patient goes for the pregnancy, there is a high chance of rupture and hemorrhage. So to prevent, at least we, as a guideline, with 3 years we follow, don't go for the pregnancy for 3 years.
Thank you. Thank you, sir.
Actually, Sambhu bhai, the answer also, just to add to Dr. Kanu, we always say that brain AVM should not be treated by radiosurgery when it has bled. The reason being, when an AVM has bled, it has a propensity to rebleed. At first year, at 16% chance, and the second year, 20% chance, and the third year, little more chance. But the radiation takes around 2 years' time for healing of the AVM. So within 2 years, if the lady becomes pregnant, because of the hormonal changes, the AVM which has not yet healed will have a higher chance of rebleed. I have a different question, Dr. Kanu. Everybody says, like radiosurgery is the best. I want to know from you, like, what are the complications of radiosurgery?
Yeah. So actually, depends upon the how much volume you are treating, how much normal volume of the brain is getting the radiation dose. So according to the Flickinger, as I told the Flickinger curve, so we are giving the 18 gray, and there is a sudden fall of radiation doses to the beyond the nidus. So we are keeping, there is a guideline, brain minus the nidus should not 12 gray should not more than 10 cc. So these are the guideline we are following. With this guideline, the necrosis components is very less. If you don't follow the guideline, necrosis will be high. One thing. Second thing, is the hemorrhage and all things are increasing with after radiosurgery? No. So this is the, as per the things, as per the normal complications, it may come, as in, but hemorrhage does not increase. The only thing is that only people worry about the radionecrosis. That is the only complication. Sometimes there is a edema increases, where the hyper T2 changes that make a patient go for asymptomatic brain head, mostly headache they come. We have to give the steroids to decrease the edema. And this is the, and sometimes rarely cyst formation occurs in that area. So that are the manageable side effects. But long-term side effects, like a second malignancy and all things, there are very rare cases reported, but these are the brain radionecrosis, people tell. It is, now it is decreased by high technique, plannings and everything.
Because in 2007, I've seen a lady, very young lady, unmarried, 22, 23 years, who had a brain AVM and was treated by radiosurgery in Mumbai. She has come to Visakhapatnam when I was very young, 2 years into the practice, with a brain AVM, and which has ultimately led to a brain abscess after the radiosurgery. It is not to say radiosurgery is bad, but it is my personal experience that a young lady had brain abscess, which we could not treat. The neurosurgeon and altogether the team could not treat, and the patient died ultimately next 6 years. And next 6 months, since she reported first to us. So radiosurgery
for brain AVM, leading to brain abscess, and patient expired. This is once I have seen.
No.
But it's not to tell that the procedure is bad. Very fantastic job. Thank you. Thank you, Karthik.
Thank you, bhai. I gained experience after sending your cases also. I have treated.
Thank you so much, sir, for the wonderful presentation. Now we are moving to the last but not least topic for today, that is vasospasm management in patients with aneurysmal SAH by Aravind, sir. Please welcome, sir.
So we are at the tail end of a 2-day conference on a Sunday. Beautiful weather outside. So I'll send you home very quickly. So I'm Dr. Arvind, and this is the last topic for today. So, and my topic is vasospasm in aneurysmal SAH. So I have just simplified the numbers. We can say roughly 20% of strokes are hemorrhagic, of which 10% are because of an SAH and 10% is because of an IC bleed. So there are numerous etiologies for an SAH, of which the most common is a ruptured saccular aneurysm. Since this day 2 has been predominantly focused on aneurysm, I have just highlighted it. These are some simple statistics regarding SAH. So the overall crude global incidence is about 7.9 per 100,000 years. And in Asia, the incidence is on the lower side, it's about 3.7. And this is excluding Japan, because Japan seems to have an exceedingly high rate of aneurysmal ruptures. And the most commonly, it affects people in the working age group, it is 40 to 60, with a mean of 50 to 55 years. And there is a slightly higher female preponderance. The male to female ratio is 7:10. One sad thing about this, 26% people die before reaching the hospital, and 13% die in the hospital. So numerous risk factors have been postulated. One thing is the aneurysm size and location. Larger the aneurysm, more likely it is to bleed. And posterior circulation aneurysms are also having a higher incidence of bleeding. Cigarette smoking, obviously. For every disease pathology, we will label cigarettes. Hypertension. Genetic risk factors. So genetic risk factors including family, where you have, if you have more than 2 first-degree relatives who have aneurysms, so you are more than 12% more likely to develop, to detect an aneurysm within yourself. Alcohol and of course sympathomimetic drugs like cocaine and methamphetamines. So like the average prevalence of an aneurysm is 3 to 5% in the general population. However, rupture occurs in only 3 to 25% per 100,000 population. So that means just because you have an aneurysm, it doesn't usually bleed. And so we do not know why a particular aneurysm bleeds per se. In a majority of the cases, there is no identifiable trigger that has led to this aneurysm bleeding. And most of the time, the aneurysm rupture happens sometimes even in sleep also. Some triggers have been postulated. These include physical exertion, excessive caffeine consumption, emotionally charged situations like acute anger, and sometimes sexual exertion. So what happens when an aneurysm ruptures? It bleeds into the CSF under arterial pressure. Then the blood, it quickly spreads throughout the CSF, and depending on the location, it can be within the parenchyma, and it can also affect the intraventricular areas also. The bleeding usually lasts for only few seconds, And there is a high chance of ruptured aneurysm to rebleed again. Once an aneurysm rebleeds, the chances of mortality are as high as 80%. And majority usually bleed within the 2nd to 12th hour of the initial rupture. And most of the problems you see, or the neurological sequel you see following an aneurysmal subarachnoid hemorrhage is what that contributes to the brain injury. So this is just a brief highlight of the various methods of pathophysiologies we see. So apart from having vasospasm, we also notice cortical spreading depolarization, microthrombosis, breakdown of the blood-brain barrier, cerebral edema, oxidative stress, and all these factors contribute to the neuroinflammation as well as the poor outcomes. So most patients, they initially complain with a severe headache of sudden onset, and the headache is usually, otherwise for people with known history of headaches, they say it is the worst headache of their life. And the headache is characterized by reaching its peak intensity very, very shortly. So the Ottawa SAH rule has a 100% sensitivity for finding a subarachnoid hemorrhage, provided that the patient meets any of the following 6 characteristics. It is applicable for any person over the age of 15 years. So if the patient is more than 40 years of age, patient has neck pain or stiffness, so he was witnessed to have a loss of consciousness. So if there is a preceding exertion or a physical activity before the onset of the headache, thunderclap headache or sentinel headache, which is a headache which reaches its peak intensity very, very quickly, and of course, limited neck flexion on examination. So these are all standard investigations we do to rule out a case of SAH. Of course, CT, everybody knows, readily available. And sometimes when the bleed is not readily visible on a lumbar puncture, on a CT, then we go ahead with a lumbar puncture. However, if the patient has an isolated headache, the CT has been done within the first 6 hours, and it was reviewed by an expert reviewer or a radiologist, then you did not go ahead with a lumbar puncture. Nowadays, if the facilities are available, brain MRI can also be employed. So next step in management is identifying the source of the bleed. DSA is the gold standard. However, MR and CT angiograms can also be done. So few points I wanted to highlight is once you identify the source of the bleed, the first step we have to ensure is to stabilize the patient. So for that we will secure the airway, breathing and circulation. Then we have various grades grading scales which are available. So this will classify the aneurysm depending on its severity, the SAH and severity. And next, studies indicate that shifting the patient to a expert center or a center with high case volumes of such similar cases usually improves the outcome compared to a low volume center. And another reason is, apart from the neurological sequelae and consequences, we have other associated medical complaints like cardiopulmonary, AKIs, fevers, systemic inflammatory response syndrome, protein malnutrition. So that is why we would like to have a multidisciplinary team approach with varieties of specialists all working together so as to improve the outcomes. So the first thing we have to do, or the first thing that has to be done, is to secure the aneurysm so that we can prevent a rebleed. Even if you are unable to achieve a complete occlusion or obliteration of the aneurysmal sac, at least partial treatment is better than no treatment. So ASAH, which is aneurysmal subarachnoid hemorrhage, has a myriad of complications. So today I'll be focusing on only one topic, which is vasospasm, because I want to send you all home very early. Next. So people like me who are physicians, sometimes we have doubts as to what is the correct level of blood BP you have to maintain. So the main target should be that we have to avoid hypertension and we have to avoid hypotension. So we would like to keep the BP variation to as minimal as possible. Usually a systolic BP below 160 or a MAP below 110 is supposed to be good. And this is usually achieved by using agents such as labetalol, enalapril, nicardipine, etc. So next is attaining hemostasis. So sometimes the patient may be on anticoagulants. If a direct reversal agent is available, we will definitely go ahead with it. For dabigatran, it is a drug called itarucizumab, and the brand name I believe is called Praxbind. If that is not available for factor 10A inhibitors, we can go ahead with prothrombin complex concentrates or andizanate alpha. Usually routine use of tranexamic acid is not generally recommended, not specifically harmful, but neither is it beneficial. And regarding DVT prophylaxis, if the aneurysm is secured, you have done your treatment, whether it's clipping or coiling, then definitely you can go ahead with chemoprophylaxis with either fractionated low molecular weight heparin or unfractionated heparin. Otherwise, intermittent pneumatic compression devices are useful. Seizure prophylaxis is somewhat controversial. Sometimes in our routine practice, we do not hesitate, we give off despite the evidence. However, we have to weigh the potential risks and benefits. So what we see is we usually prefer anti-epileptic that has a favorable neurological profile. Phenytoin should be avoided at all costs, and what we evaluate is the relatively low incidence of side effects versus the potentially devastating effect seizure has in a patient with aneurysmal subarachnoid hemorrhage. So this slide I have appropriated from the American Heart Association. This is the 2023 aneurysmal subarachnoid hemorrhage guidelines. So if a patient does not have any high risk features of seizures or high risk features in ASAH, that is a ruptured MCA bifurcation, ruptured MCA aneurysm, high grade SAH, hydrocephalus and raised ICP, continuous EEG, electroencephalogram monitoring can be employed if the facilities are available. So if the patient has high risk features, you can go ahead with anti-epileptic medication. However, phenytoin has to be avoided as it is potentially very, very harmful. And if the patient does not have any high risk features, he might not benefit from prophylactic seizure medication, anti-seizure medication. So treatment is better if it is contained to less than 7 days, provided that the patient has no history of epilepsy. Now, coming about vasospasm. So as we know, the blood vessel has 3 different layers, and the middle layer is tunica media, which is a muscular layer. And when it becomes spastic, it narrows, leading to the sequel. So whenever there's an aneurysm, it has a sac, it ruptures, blood pours into the CSF, the blood clots, and some of the free blood, they start degrading. And these degrading products are postulated to cause some of the deleterious effects. Out of these, in this entire picture of pathogenesis, I would like to point out towards the last 2 highlighted areas. One is that when the endothelium is damaged, the intravascular nitrous oxide production is somewhat hampered, and nitrous oxide usually tonically dilates the cerebral vasculature, so that is gone. And there is also increased accumulation of endothelin-1, which is a very, very potent vasoconstrictor. So both these steps together contribute to the vasospasm. This is just a repeat of the previous slide. So delayed cerebral ischemia is a very common complication of SAH, and it is seen in about 30% of the patients. It contributes significantly to the morbidity and mortality, and usually occurs between the 4th and the 14th day post-ictus. So how do you identify a DCI, delayed cerebral ischemia? First of all, there should be a focused focal neurological deficit, whether it is hemianopia, hemiparesis, aphasia, apraxia, whatever it is, or there should be a 2-point drop in the patient's GCS. And even after detailed physical examination, imaging, and laboratory studies, if you are unable to attribute it to any other cause, then we would like to call it as a delayed cerebral ischemia. The problem is not every patient with aneurysmal subarachnoid hemorrhage has a good sensorium, so that poses a problem to us. So there are two different types of patterns that we see. One is a single cortical infarct that is very close to the aneurysm, and widespread multiple infarcts, and both are seen in 40 and 50% of the patients in whom we see DCI. There are numerous risk factors for vasospasm. One is the severity of the bleed. More is the quantity of the bleed, more is the likelihood of vasospasm. Next, if the bleed is very proximal to a major intracranial vessel, then, as we have discussed, younger age groups tend to have higher chances of vasospasm. Hyperglycemia is apparently a risk factor. Initial poor clinical presentation. Then the type of aneurysms and the treatment that have been employed for the aneurysm. So there are some studies which say endovascular treatment gives rise to more vasospasm. There are another set of studies which say that surgical management or clipping gives rise to more vasospasm, and some studies point towards equivocal results. So depending on your source and how you like to treat, it keeps on varying. And you can employ some grading scales like Fisher scale and the modified Fisher scale. It's also called the Klassen scale to predict the likelihood of a vasospasm in the patient. This is just a picture of Fisher scale, the modified Fisher scale. So how do you detect DCI? One, the easiest, cheapest way, provided you have staff who can do it for you, is a frequent neurological examination, particularly in the first few days post-ictal. Otherwise, if your institute permits, you can employ transcranial Doppler. So because it's a non-invasive method, it can be repeated regularly. However, it is extremely operator dependent with varying sensitivity and specificity. And even if you find any abnormality, you have to confirm later with a more, an extensive vascular imaging modality like an angiogram. So what this Doppler detects is a change in the blood flow velocities. Sometimes these changes can be apparent even before clinical symptoms appear. Then we have brain imaging and vascular imaging. So we can employ CT angiogram with CT perfusion. However, there is the risk of radiation exposure and frequent dye loading, which can be harmful for the kidneys. However, this is a non-invasive modality. There are some studies which suggest that you can use MRI with perfusion-diffusion mismatches also. However, I think further studies need to be done to advocate their use. Continuous EEG monitoring if facilities are available. Even if you might not be able to detect vasospasm, if there's a sudden neurological deterioration in a patient, it might be because of a subclinical seizure. It might be because of non-convulsive status epilepticus. At least we can rule out those conditions. So these are some modalities that some institutes employ. One is a daily transcranial Doppler. Second, we can repeat a CT angiogram, a plain CT with CT angiogram and CT perfusion. First on admission, second somewhere between day 3 and day 5, and finally on day 7 and day 10. DSA can also be employed in place of CTA. So this is a small schematic to summarize it. Usually transcranial Doppler, CT imaging and neurological examination, they provide data in an intermittent fashion depending on how frequently we employ. So brain tissue oxygen monitoring and cerebral microdialysis are some newer improvements. However, we are not using them. Yesterday, Dr. Gundadhar Padi was kind enough to brief us about cerebral microdialysis, so I'll not go into detail about it. So, just because you find a vasospastic segment in an angiogram does not mean it necessarily requires treatment. So, vasospastic segments can be seen in 30 to 70% of angiograms. However, only 20 to 30% of them show clinical signs. And aggressive treatment of a vasospasm can only be started once the aneurysm has been secured. And the first component of it is maintaining euvolemia. So as we know, if a patient develops hypovolemia, there is a very likelihood that his cerebral perfusion pressure drops, which is very, very harmful for the recovering brain. So normal saline is usually employed, but any crystalloid can be used. And when you target euvolemia, we would also like to maintain a normal electrolyte balance, because as we know, hyponatremia is very, very common in SAH. So how you maintain euvolemia depends upon your preference. Usually we employ a combination of these features: central venous pressure monitoring, echocardiography, and strict input-output charting. So hemodynamic augmentation is usually considered the first step. So in this, we employ some vasopressors along with IV fluids to achieve this. And in this augmentation, we would like to increase the BP in a step-by-step manner so as to maintain the cerebral perfusion pressure. And every time we increase the BP slightly, we would like to confirm that we are not harming the patient by doing routine neurological examination. Just because, so this hypervolemia should not be used to prevent, it should only be used to treat. So nimodipine, everybody knows about nimodipine. So the dose can be up to 60 milligrams every 4 hours. And it can be initiated as early as possible, provided the patient is stable. So we would like to continue it for up to 21 days. Preferred route of administration is either through an NGT or through the mouth as an oral tablet. So numerous studies have been done which demonstrate the benefits of administering nimodipine to a patient. So one, compared to the placebo, the odds of having a good outcome are 1.86 times higher. It's very, very good. Then there is a reduction in mortality, morbidity, and their combination by about 0.46. There is a reduced rate of delayed cerebral ischemia by 0.53 times, and there is an overall reduction in mortality by 0.73. And the number needed to treat with nimodipine to prevent one bad outcome is about 13, which is very good. So we do not exactly know what is the mechanism of operation for nimodipine and how it benefits us, but these are some postulated hypotheses. One is neuroprotection via dilation of very, very small arteries, which might not be apparent on an angiogram. Second, reduction of calcium-dependent excitotoxicity. It might diminish the platelet aggregation, and it inhibition of ischemia triggered by red blood cell products, or Usually, it is thought to be a combination of all of these above mentioned hypotheses. So what are the side effects? Very most commonly, if we see, is fluctuation in blood pressure and hypotension. Next is milrinone. We routinely use this for patients who require them, as our intensivist Dr. Ram Naidu sir can attest. So numerous studies have been done about milrinone. So milrinone, presently we are talking about an IV administration. So this milrispasm controlled before and after study, it compared a few hundred patients where they were compared with the placebo as well as IV administration of milrinone. In the milrinone group, about 29% people had to prematurely terminate their therapy because of few side effects. However, of the people who tolerated this procedure, there was a significant reduction in the need for rescue therapy, or there's a significant reduction in the appearance of vasospasm that required further management. And this is another study where they compared IV milrinone with a cohort of patients who were treated with both IV milrinone as well as intra-arterial milrinone. And they found that administering IV milrinone alone was comparable to IV plus intra-arterial administration. And this is systematic review done which has compared all the previous existing studies on milrinone for vasospasm in aneurysmal subarachnoid hemorrhage. So out of these 22 studies which were included in this review, 21 studies showed benefit of administering milrinone. The dose is about 0.5 micrograms per kg per minute, can be given up to 14 days. So in all these studies, the most commonly seen side effects were polyuria, hyponatremia, and hypokalemia. Serious complications, serious side effects like thromboembolism, arrhythmias, and myocardial infarctions were relatively very rare. Another modality, if you have detected a vasospasm on your follow-up angiogram, then you have tried hypervolemia, euvolemia, and you have given the necessary medication, but still if it is refractory, then you might require endovascular treatment modalities. One such method is catheter-directed administration of this dilator very close to the source of the vasospasm. So these are some of the medicines that have been used. In our center, I believe we commonly use nimodipine, sir. So the next modality is balloon angioplasty. So this is a paper written by our team. So I've had this, one of the first papers that Dr. Dalai sir and I wrote. This was our center experience where we used balloon angioplasty. When a vessel becomes very spastic and narrowed, you pass a balloon across it, dilate it, and it confers a structural change within the muscle fibers, which prevents it from re-occluding or becoming re-narrowed again. So with this, a happy Sunday, and thank you for your patience. I know it's a very hectic day, long day. So before I send you all home, the certificates will take about 2 weeks because they have to go back to Vijayawada to get authenticated, and then we will receive them. Secondly, I would like to grab the mic and use this stage to say my vote of thanks, but that is after I have any questions from the moderators and chairpersons.
It's a very good talk, Dr. Arvind, and very nicely presented. Every aspect has been covered. I think if you have more time, I think you will be able to speak more also. But anyways, it's very good that you have quoted the evidence as well, the recent literature. Only from 2019 onwards, we have been having extensive papers regarding intravenous infusion of milrinone. Earlier, milrinone was IV infusion was used only for acute decompensated heart failure. But now when prevention of delayed cerebral ischemia and those patients who have higher Fisher grade of subarachnoid hemorrhages, instead of using rescue therapy as intra-arterial therapy, we are using intravenous infusions also. So that's very good that you've mentioned everything. Thank you for the nice talk.
So now we would like Dr. Manas Panigrahi sir to come onto the dais to provide mementos to our chairpersons.
Questions?
Sir?
Questions after the talk.
Sunday no sir, it's a beautiful evening outside.
Yeah, can I ask one?
Yes sir, please sir.
Actually, one particular slide you were showing that to raise the BP, you use both crystalloid and colloids. But as per as critical care, if you see the current guidelines, colloids, they are not preferring now, in especially critical set because of high incidence of AKI. So that is one. And other newer therapies have come, some of them the ET1 inhibitors. Actually, one slide you are showing that ET1 is one of the target, endothelin 1. So that ET1 inhibitors are coming now in this reducing the vasospasm. And erythropoietin is also being used. And milrinone, as sir told, now it has gone from heart failure. In heart failure, milrinone is no more used. Now if you see the current 2023, only 5 or 6 therapies, including acute heart therapies also, we are mostly using diuretics and other. Milrinone has gone. Now probably it will be more useful in this type of scenarios. Yeah, that's all.
Yes, sir. Thanks. So now I would like to call upon Dr. Manas Panigrahi sir onto the dais to present the mementos. Sorry for troubling you all. They will get here. So first, we would like to call Dr. Sambudatta sir to receive his memento from Dr. Manas Panigrahi. Next, Dr. Mohan V. Sumeda Maturu. So before sir changed the teams, he was part of our team at Medicover. Next, I would like to ask Dr. Ram Naidu sir to receive his memento. Thank you. So, thank you, sir, for your time. So, with this, I would like to begin the vote of thanks to conclude this event. And my memento Dalai sir will give. I will give my Dalai sir his memento. We will extend mementos. Next, I would like to call Dr. K.C. Patra onto the stage to receive his memento from Dr. Mohan V. Sumeda Maturu.
I request Dalai sir to come on to dais to receive his memento. Yes, sir.
Then
I request
requesting Dr. Suresh sir
present
and
the
Dalai sir
memento.
onto the stage.
I request Dalai sir to present memento for Arvind sir. So if there are no further interruptions, I would like to start the vote of thanks. So even if they are not here, we would like to thank the Indian Society of Neuroradiology, its president Dr. Sailesh Gaikwad sir, for giving us the opportunity to host all you lovely people here in Vizag. Second, I would like to thank Dr. Dalai sir. Though he says we are part of the same organizing team, I believe he is the only organizer in the team. So he has taken care of majority of it, both the front end, back end, middle end, all ends. Then I would like to thank myself for being here. And with this, very good evening to all of you. Hope to see you next year at an even bigger meeting, preferably international.